Good morning. I'd like to call the House Finance Committee focus hearings to order for November 16th, 2021. I apologize for being a few minutes late, but we have a number of members who are who commute, and they're having a problem doing that today with I think I-65 is shut down coming into town from the north, and there's a wreck on 24 and perhaps some other obstacles that are interfering with people's timely arrival. So, but at any rate, I do apologize for us being a few minutes late. We will try and make that time up today. Madam Clerk, would you please call the roll?
Representatives Campbell, Camper, Crawford, Faison, Freeman, Gant, Garrett, Gillespie, Hawk, Hicks, Lamar, Lambert, Lynn, Miller, Ogles, Sexton, Shaw, Sparks, Todd, Whitson, Williams, Wendell, Zachary, Vice Chairman Baum, Chair Lady Hazelwood.
Here. Thank you, Madam Clerk. Are there any personal orders or announcements? Chairman Williams, you're recognized.
Thank you. This has nothing to do with this committee today, but I wanted to thank Representative Freeman for bringing donuts this morning. As a fine connoisseur of donuts, they do not achieve Ralph status, but they are fantastic from the Donut Den in Green Hills. Thank you.
Representative Freeman, your name was called.
Thank you. I appreciate the challenge any day for a donut challenge competition, tasting competition. So just let me know when.
Any donut is a good donut in my book, especially this early in the morning. So thank you. Before we get underway, I would like to note that the hearings are being live streamed for anyone that's unable to attend, including some of our members who, as we noted yesterday, are not with us. And the supporting documents for each agency are available on your dashboard. And again, just as a reminder, the hearings that we did yesterday and today are focusing primarily on the federal COVID relief funding dollars that have come into the state and into the departments since we put together our budget for the current year. So we have 3 hearings scheduled today. We'll begin with, if you need waking up in the morning, we thought about this and we put Commissioner Williams first on our agenda, because if anybody's still napping, we all know that she's enthusiastic and passionate, and will make sure that we're all attentive. So Commissioner Williams, with you and your team, please come forward.
Good morning, Madam Chair Hazelwood and very distinguished members of this committee. We are so grateful to be here with you guys this morning. Yesterday I watched Representative Lambert, Chair Lambert, Leader Lambert, and I thought, dang, he is very excited. And I thought, if he's going to be here, we're going to have a great time today because of his energy and enthusiasm. So I look forward to those of you that have that energy and enthusiasm being here with us and talking through what we've done with COVID with us. At the table with me to my right is Deputy Commissioner Matt Yancey. He serves as our Community Behavioral Health Deputy Commissioner. To the left is Todd Thornton, who serves as our Chief of Staff, and he's also over all of our hospital operations. To the right is Gene Wood. As y'all know, he's our longtime incredible Director of Budget. And then to his right is Heather Gunderson, who serves as our Deputy Commissioner over Admin Services and Operations. Again, we are excited to be here. And as we looked at what you sent us to fill out, what we wanted to do was to first start with context as it relates to what sort of happened in this state during COVID and during this pandemic. So if you turn to the first slide, you'll see part of the context really lies in our mission and our vision, and that really outlines how we have spent and utilized the COVID dollars to date. First one is creating collaborative pathways to resiliency, recovery, and independence. And this is for Tennesseans who are living with mental illness and substance use disorders. If you look at our vision, you'll note a state of resiliency, recovery, and independence in which Tennesseans living with mental illness and substance use disorder can thrive. So those two things really guide what we do and how we do. If you go to the next slide, you'll look at what we value in our department and what we value in the providers that many of you all already know you have relationships with across your districts. And the first value is customer focused. We have an unwavering commitment to making sure that the customers that come before us get what they need. Oftentimes that's you all. You will call, you will send an email and ask for information, and we do our absolute best to get it back to you as soon as possible. Integrity. You will note that we are honest and truthful in all that we do in our department. Inspired purpose, that call to action that underlines and undergirds all that we do as we look at those people that we are blessed to serve. Excellence, which is the highest in standards for services, efficiency, and conduct. Compassionate and effective leadership, which is something that I can tell you our whole leadership team has, as well as the providers that we fund. Solutions and outcomes focused. You will note that the dollars that we give out, whether they're dollars that you all allocate to us or these COVID dollars, are focused on solutions and outcomes, and we track all of that. And then finally, partnership. Because we know without partners across the state, we won't be able to accomplish anything on behalf of those individuals that, again, we are blessed to serve. Going to the next slide, I wanted to point out to you the pre-pandemic stats. And I want to make sure that's in your mind. This is pre-pandemic because it's the latest we have from our data sources from SAMHSA and the national prevalence data sources. What you'll see there as it relates to serious mental illness, we have about 378,000 individuals pre-pandemic across the state that have been seen by prevalence data to have serious mental illness. And these are mental illnesses that include schizophrenia, bipolar, debilitating depression. And so we're talking about the most seriously mentally ill. And what you'll note there that we've been so proud of because of the dollars you guys have given us through the safety net is in the last year, we were able to serve 39,840 Tennesseans that were uninsured. And if you look at the overall uninsured number, you will note that that's right at 42,980. So because of your support, the governor's budget, we're really meeting that need pre-pandemic for the uninsured individuals.
Commissioner, if I might just stop you for a second. These
Yes.
numbers that we're talking about, are these adult
Yes, ma'am.
numbers? So this does not include children who've been diagnosed or being treated with
It does
mental
not,
illness.
and we do have those numbers.
Thank you.
For this purpose, I focused on adults, but we had the children's number as well. When you look at the estimated prevalence of substance use disorder, again, that states among adults in Tennessee, you will note that pre-pandemic, we had 458,950 Tennesseans that had prevalence data that seemed that they had a substance addiction. We're not doing so great there, although we're doing our very best to allocate dollars to meet that need. You will note that 52,180 of that population are uninsured. However, with the funds we've got, we've only been able to serve right at 20,000. As we go over the COVID funds, you will note that we're really trying to expand and really narrow that gap because we know that if you do not have treated substance addiction, it impacts every area in your life, your family's life, your church's life, your school life, your work life. It impacts all of us if we're not doing a good job at meeting those needs. And then finally, going to our last slide, which is why I said, pre-pandemic. This is very telling. As we've gone through the pandemic, sources both through the Tennessee Department of Health and also sources through East Tennessee State University, as well as the Kaiser Family Foundation. All three of these areas stated that we had seen a 45% increase in overdose deaths of all substances. That is troubling. I know that you guys have talked to TBI Director Roush. I know that you understand that this really isn't related to the original substance that we focused on, which was opioids in pill form. It really is focused on drugs that have been laced now with fentanyl that are being sold on the streets, and people aren't aware that that is what they are ingesting. And so we've got a lot more people that have an addiction issue taking a pill that they really don't know what's in it, or any other kind of substance that they don't really know what's in it. And then you'll note on the next part of this slide is the self-reported symptoms of anxiety or depression. Again, this is very troubling, and we will see fallout from this, as we already are. We have seen increases in anxiety and depression that have gone as high as 43.5% during the pandemic. It's now down to 34.6%, but that's over and above what we've typically seen in our state, which is right around 20% of the population. So as y'all know, that is going to trickle down as it relates to what kinds of programs and services that we are able to fund and what we do. Finally, looking at the packet that we sent and answered the questions that you all asked us to answer, you will note that our funding in total through the COVID dollars is right at $54,627,059. And then that breakout, you will note on that first page, really goes into CARES funding. That was $2 million in the first round. The Paycheck Protection Act funding, $2 million in the first round, and then $2 million in the second round. The consolidated appropriations for crisis programs through the COVID funds, which was $2.8 million. And then finally, this biggest amount of funding that goes to our block grant that we get annually, they actually bumped up that block grant. That now has been allocated at $45,767,412. I do want you to understand that the low amount of funding that's been allocated from that money is due in part to two things. We did not get approval to move forward on this money for the mental health side until March of this year. And then you have to go through, as you all know, the whole contracting period and all that. So that's delayed that. On the substance abuse side, we didn't get that until August of this year. So I want you each to know that we are going to spend these dollars and that we really did have a major delay in those two as it relates to being able to even draw it down and allocate it to the providers that are across our state. With that, Madam Chair, we will conclude our presentation, and we look forward to any questions that you might have.
Thank you, Commissioner. A sobering presentation for all of us. It's and I guess discouraging in some ways because we were making such really positive progress prior to COVID, and just underlines the need to make sure that we're using these federal dollars in a way that really addresses the increased need and issues. So do have several people with questions on my list, beginning with Chairman Hawk.
Thank you, Madam Chair and Commissioner. Thank you so much for you and your team. And my questions were going to be around the federal funding and the how and why we've not been able to invest those dollars as much. You've given a pretty good explanation as to why we've not invested those dollars. Can you tell me exactly how we're going to be able to invest those dollars in the future? Are these reimbursements to us, or how are these dollars going to flow eventually, and the timing of that?
Absolutely. So as I said, we on that last area, which is really our biggest concern, that big amount, we've been able to move forward and allocate dollars to our providers. And I want y'all to know how we did this, which is very different. And the federal government really liked this idea that we pitched. Because these are time-limited funds, which means after they're spent, they're not going to be here anymore unless the federal government decides to continue to fund them. What we did is we asked our providers because each provider has different strengths and weaknesses and different opportunities in their community, to come back to us within the rubric of what these funds will fund and tell us, what can you do with this prorated amount in your community over the next 2 years? So each provider, each community is going to be bringing back in, and some have already come in that we've already started contracting with, to do projects that meet those gaps and needs. So for example, with the substance abuse community, they're going to be asking for that continuum of care. I can't imagine that anyone would not ask for that, because we've got that gap related to individuals that are uninsured that need treatment. So our plans are to utilize what the block grant allows us to do, which is pretty much any kind of intervention for individuals that are seriously, persistently mentally ill on the mental health side, and then on the substance abuse side for individuals that are struggling with addiction. And so that's our plan to utilize those funds.
Chairman Hawk, you have a follow-up?
Yes, ma'am. Thank you, Madam Chair, and thank you for that answer. And you bring up one of the most important facets of the work that your department does and that we need done in the state of Tennessee, those providers, the work that they do. And I'll go back to slide 3 that you gave to us, the last point of partnerships that we've got built. Or that we have built and continue to nurture across the state of Tennessee. I'm very concerned at this moment in time that staffing levels within our provider community are at a almost a crisis
Yes, sir.
point.
Yes, sir.
Both in terms of being able to compensate these positions and as well as being able to recruit folks into these social services, behavioral health treatment occupations. And we're at a place now where we really need to make sure that we're investing in these services because our providers across the state are having challenges, having budget challenges. Anything that we can do as we work with our payee, with our Tenncare system and our provider HMOs that are working within this system, we need to ensure that we're all on the same page, pulling in the same directions. Any comments on that, Madam?
Yes, sir. And I really appreciate you bringing this up. This past year, we joined with Tenncare, and I'm so grateful for Deputy Commissioner Yancey's leadership. We have led a statewide workforce initiative work group that is finalized with our draft of recommendations. And we are also concerned. Tenncare is concerned. We're concerned. And what I'm grateful for is that we're working in partnership with one another. The proposals that you'll see in this year's budget request, if you saw what we said to the governor in our budget request, really focus on that workforce issue. And I would like to ask Deputy Commissioner Yancey, anything you want to add about what we've seen in the work group specifics?
Yes, ma'am. So as the commissioner said, we convened a work group with Tenncare over the summer. We met 3 times, and we had a diverse group of folks work with us, people from colleges, universities, provider organizations, other nonprofits, advocacy groups, and they really helped us better understand how quite acute the situation is. I was actually on the phone last week, Chairman, with Christy Hammonds from Frontier Health, and she was talking about the workforce issues that they're experiencing there. So as the commissioner mentioned, we took the feedback from this work group to help really drive our budget request for this year, looking at not only immediate needs of the provider community, but also pipeline planning. What can we do as a state to bring more people in to the public behavioral health workforce? Because we know we got to think future forward. The data bears out that there will continue to be a growing need around mental health and substance use. And our system is only as strong as our provider network and the people who staff it. So we are soon to release the report from the work group. That's gone through the final stages of approval. And we'll certainly make sure that this body has a copy of that once released.
Next on my list, Chairman Williams.
Thank you, Commissioner and staff, for coming today. I just had a couple of questions about the block grant. As it looks in the spreadsheet, a little over $22 million. We spent $297,000 of that. I guess the question is do we have a process by which we people can submit for these grants. One of the common things we heard yesterday, and sounds like we're going to hear today, is we have all this federal printed money and we haven't really spent a whole lot of it. And so I guess the question would be, what is the process for doing that? And so you could share it with us so that others might be able to hear that.
Yes, sir. One of the things that we were talking about is on that particular amount, which is that fourth line item, it's broken down into two areas: mental health block grant, which again, we didn't get until March. So we've already allocated those funds related to doing like a tier allocation by need and by provider. And that's where I was saying they're sending in to us how they're going to spend it, because it's one-time funding, short term. So it'll be by provider, by district. Then on the second part of that, which was the substance abuse, we didn't get that approval until August. We're doing the same thing. So I'm not concerned that we won't be able to spend these funds. It was really, we got held up on those. On the ones above that, you'll note they're allocated and being spent. But that block grant one, which is the largest one, really, we didn't even get approval until March for the first part and August for the second part.
Just to follow up on those monies that you have awarded already, what
Yes.
is the average award for one of those?
That's a great
grantees?
question. We've got a whole list of what we've awarded. And I will ask Deputy Commissioner Yancey if you want to sort of give a low to the high.
Yes, sir. So it's a range. So in the mental health block grant supplement, we're funding, I think, over 30 providers. With the substance abuse block grant, it's well over 100. So when you think about our department and how we do our work in the community, it's through a wide variety of local community organizations. So to your question about the range, it could be a grant amount as small as $20,000 all the way up to $1.5 million based on the size of the organization. You know, I mentioned Frontier, so our larger community mental health centers who do a lot of our work, they'll see more funds coming in from these block grants than maybe a smaller provider that's only serving a smaller number of people in a smaller community.
And we've got the complete list. So if anybody in your district wants to get that list, we can give it to you.
Chairman Baum.
Thank you, Madam Chair, and thank you, Commissioner, and your team for being here. I've got a question or two about the state's use of the federal funds, the portion of them that we have spent so far. What portion of those funds have we spent on existing programs versus new programs that have been created in order to spend those funds?
Right. Now, I can't give you an actual percentage, but I can tell you roundabout. Again, for the substance abuse side, we know we got that gap that I talked about. And so for those funds, we're really funding what works that we have to expand capacity, right? So you're talking about detox programs, you're talking about inpatient programs, you're talking about residential, you're talking about aftercare. So on that part of money, that's what we're funding. On the mental health side, we are funding a lot of what's out there already to expand access, especially since numbers have grown with the pandemic related to mental health individuals. So things like care coordination, case management, medication management, crisis services have gotten a big bump because we've seen that more people are having crisis. So you need to have our providers have those staff. So does that help?
Yes, and for those new programs that may have been created,
Mhm.
are there any that you would that have worked really well that you would
Yes.
want to continue even after the federal funds cease?
Yes, sir. And thank you for asking about that. Our Project Rural Recovery is a program that I wish we had thought about a long time ago. Many of you have participated in conversations and discussions about the transportation problem in rural communities, right? And so we tried our best to solve the transportation problem, and we haven't got real far with that. So what we did is we came together and wrote a federal grant really prior to the COVID funds and said, hey, why don't we go to the people? Why don't we have a mobile van that goes, that's part of that community where people can get the care and treatment that they need versus trying to figure out how to pay people to go to a site. So that is a program that we are excited about. We've been able to expand it with these dollars. And I know, Deputy Commissioner, if you want to give an idea of where we expanded these to, I'd appreciate it.
Yes, ma'am. So the commissioner mentioned Project Rural Recovery. I mean, when I think about our department, I think about what we're trying to do to increase access. It's all about going to where people naturally are. So we've done a lot of work with school-based mental health. We're putting people in schools to work with students. We're working obviously closely with the justice system with our criminal justice liaison program. I think Project Rural Recovery is an example of where we're going to these hard to reach communities where people may not have a brick and mortar mental health center or substance use treatment center there in their community. So we're going there through these mobile units. But with these federal dollars, we've been able to, I think, reinforce what we know that works. We're using these monies to do more medication assisted treatment. We're providing more funding to our behavioral health safety net providers. But as the commissioner said, we've also given the provider some flexibility to say, tell us what's missing. What are the gaps in your community? So I was looking at the list of things that we're funding outside of the normal. And for example, volunteer behavioral health is doing co-response models with some of these federal dollars. Helen Ross McNabb in Knoxville is actually partnering with the University of Tennessee to bring mental health services to the campus. So it's really a blend of doing what we know that works and putting those dollars behind those evidence-based programs, but also giving some flexibility to do new innovative things.
And maybe one more follow-up. Is there any variation in expenditures across the state? How we've spent the federal funds more in East Tennessee versus Middle Tennessee or West Tennessee?
That's a great question, and that goes to what we do related to data. I really appreciate you asking that. You will note that we have an Office of Research and Planning, and so we look at many indicators when we spend money. We look at prevalence data by county. We look at poverty level by county because we know the higher the poverty level, the harder it is to access services. We look at penetration around Tenncare, like how many people are on Tenncare. Like we have a really great way that we look at that. So depending upon what the program is, so for instance, substance abuse, when we focused on opioids, you'll note that that really focused in East Tennessee. That was where the highest need was, and that was in the beginning. But as time went on, it came to West and it came to Middle. And so we had to reapportion dollars based on what we were seeing by data. So I can tell you that what we do is data driven, and we really do look at county level, at regional level as to how we allocate dollars to providers.
Okay, thank you.
Thank you.
Thank you, Chairman. Good questions. Next on the list, Chairman Hicks.
Thank you, Chair Lady Commissioner. Certainly good to see you and your staff here. And thank you for what you do for not only in my neck of the woods, but all across the state of Tennessee. The question I have is still sticking with the federal funding component. How much has been spent when we look at the capital projects, maintenance, IT projects? How much has been spent on these, if any? And then if there has been any spent, so will we be using state funds to, I guess, going forward once the federal funds have been expended?
Thank you for asking that. As you know, this is not broken down into capital funds. So I want to ask Jean Wood, our budget director, are you aware, or Deputy Commissioner Yancey, how much of this went to capital? The majority of it's really gone to staffing and services and bringing in like the vans for the Project Rural Recovery. But as far as bricks and mortar capital, I'm not sure.
Yes, sir. So with these funds, specifically the mental health and substance abuse block grant supplemental dollars, there hasn't been a lot of investment in capital projects, primarily because there are some exclusions around that set forth by the federal funder. Gene, I don't know if you want to.
You're saying it exactly correct.
Okay, good.
Okay. That's good. We have two people that agree.
And then I'm going to jump back just for a second, talk about the Project Rural Recovery, which you spoke about. And so you answered one of my questions, which was what areas were being served, but a part of that as well. So just to make sure I'm clear, so was this an expansion of an existing program, or was this to get the program up and running? I wasn't clear on that.
Yeah, so we were able to apply for federal dollars in the beginning for Project Rural Recovery that weren't part of COVID, but this added dollars to it through the COVID funds related to that project.
Okay. Thank you very much.
Thank you.
Thank you, Chair Lady.
Thank you.
Representative Freeman.
Thank you. If you could turn it back to slide 4, please. I've got a couple of questions. So looking at this slide, what's the reason for the gap between the uninsured and those that we're serving? What are they? Do they not qualify? Are they not coming back?
Thank you for asking that. There are multiple reasons. Number one, they may not seek service. So if you look at prevalence, this is what we know across the state, but not everybody who has a serious mental illness seeks service. So that's part of the gap. The other part is if they're over 138% of federal poverty level or higher, although this is really focused on low-income individuals, that group may not be able to be served because the dollars that we're using are really for 138% of federal poverty level or below.
And then I have the same question for the
Substance
next
use?
slide.
Yes,
Yeah.
sir.
And
Yeah.
I want to note that it's of great importance to me because one of the 2,089 Tennesseans who died from substance abuse in 2019 was a family member of mine.
Okay.
So can you address the gap on slide 5, I believe it is?
Yes,
The next
sir.
slide. If you'll advance it one, please.
First, I'll say I'm sorry
there.
about your family member's death. I don't know if they were uninsured or covered by private insurance or Tenncare. And that really matters in this world as it relates to what program and services people can access. So if this person was uninsured and you go to that slide, you'll note that we have a huge gap. We have worked hard, Governor Lee, Governor Haslam, and you all have given us a lot of money over the years to try to respond to this group of people that have addiction. But as long as you have that big of a gap there, it's going to be hard to get service. And that's not just for the uninsured, that's for the insured individual. So all I can say to you is, as we get dollars, we expand the services. If you look at our overhead in our department, we only have 6% overhead. 94% of these funds go to the community. They don't stay with us.
Representative Freeman.
Sorry, one more question. And a theme that we've been asking on this panel this whole time is what are you doing to be proactive to notify Tennesseans of the additional programs? I understand the reason you gave for not expending the federal dollars that we've received, but how are we being proactive to make sure that we close that gap?
Yes, sir.
Not just there, but on mental health and all these other programs that we're rolling out.
We're doing multiple things. One is an unbelievable commercial that our director of communications has put together with News Channel 5 that really makes you stop and think related to how to call and where to call when you have a crisis, because that's your portal. If you've never accessed services and you're in a crisis or a family member's in a crisis, that ability to call. So we blanketed the market during the highest points of COVID and the pandemic. The second thing that we've done is our provider network is very responsible for within their communities letting people know about the services that are funded. And I know that they've done a lot of outreach over this pandemic to let people know what's available. We've also enhanced our website. Cannot even begin to tell you the work that this team did related to making sure if people went to our website, they knew where to get services so they could geographically look. And I can tell you, I am website challenged, and I literally can get on here and find where I need to go to get help. We expanded our 24-hour, 7-day-a-week resource with substance abuse. It's called the Red Line. When we first funded it, it was like a person would call and they would read you 35 questions. And we said, this doesn't make a lot of sense. I mean, this person's in a crisis. Asking them 35 questions when they're struggling with addiction is not going to be the way to go. So you guys gave us funding to enhance what they do. And so we have warm handoffs now that we did not have. which is very important when you're dealing again with a person that's struggling with an addiction. So those are just a small part of what we've done.
Thank you.
Thank you, sir.
And I think it's worth noting that one of the challenges here, to my mind at least, is this is not a stable population that we're able to work against. That population is growing all the time. So even as we increase services and do things more efficiently and hopefully more effectively, it's still a tsuami that's coming at you just because of the increased numbers of people who are involved. So it's a very difficult situation, obviously. Chairman Faison.
Thank you, Chair Lady. Thank y'all for being here. I have noticed, and there are a few counties who have some pilot projects when it comes to mental health courts, like we do our drug courts, we have special courts, we have military courts. And it's not publicly known, but this is something that I've been passionate about for years. My dad struggled with bipolar depression. He ended up taking his life. So it's something that's been a huge thing in my mind. You and I have spoke several times about it. So my question is this possible for the money that's come in to help us get around the state of Tennessee? I was just talking to the vice chair here, and they're doing something with mental health courts in Rutherford County, but there's no standardization at all. And I'm just wondering, is it possible that we could use this to maybe increase our ability in our court systems around Tennessee to do something? Could you speak to that? Is it something we could use this money for?
I really appreciate you asking that. As you know, since we took over the recovery courts, substance abuse courts, mental health courts, we've actually expanded those by like 70% since they came to us. And one of the areas that we really do focus on, in addition to the substance use recovery court, is mental health, because oftentimes the two are together, right? So even if you have a substance abuse court that's a recovery court, it's not just for substance addiction. You're dealing with people with mental health issues. So what I'd say to you is that for all the courts that we have that are recovery courts, to me, those are also mental health courts because they're dealing with both. And then for the mental health courts, I tell you, they deal also with addiction because it comes together. What I'd like to do is look and see if anybody applied to expand a mental health court with these funds. I don't think they have to date. Do you?
We'll have to check, Representative, but I do know with some of the block grant funds that the plan is to expand treatment for the criminal justice population. So folks who are coming through the recovery courts, we want to make sure those providers have access to funding to ensure that they get the treatment they need. That also includes using some of these funds for medication-assisted treatment, knowing that that is the evidence-based modality for folks living with opioid use disorder. So we do have budgeted to help support those recovery courts through these new federal dollars.
Chair Lady. So that's good, everything I'm hearing, but it would also sound like there's a potential for some courts to apply for additional resources for a mental health court. Is that what I understand you just said?
There's potential for the providers that work with those courts because the providers are providing the services, not the courts themselves.
Okay.
So absolutely, there's potential for that to be applied for if we haven't already gotten the application from the provider. Yeah, I was telling you earlier, we have allocated funds based upon all that research for a particular provider and region area. And so, yes, there's the opportunity if they have not already applied and been allocated.
Okay. Thank you.
Representative Lamar.
Thank you, Chair Lady. Good
Hey,
morning.
good morning.
And I apologize for my tardiness.
That's fine.
I wanted to, and I don't know if this COVID related, but I know there's a lot of more cases of youth under 18 experiencing mental distress because of virtual school, being at home, not getting meals because they have to be at home, their parents can't afford it. Is there some sort of initiative, collaboration, or anything going on uses COVID funds to provide mental health counseling in the schools for our children?
Yeah, absolutely. Thank you for asking about that. One of the things that you guys did last year is you gave us funding so that in every county in this state, there would be one school-based behavioral health liaison. I can't tell you how important that is because so often schools don't know what they can access for help for their kids, especially kids that are poor. And so we've already got that person helping in each county. And when you ask about the funds allocated, we've got the safety net, the behavioral health safety net for kids that provides the full array of services for any uninsured kid in this state. And so we're utilizing those dollars to meet that need, but also utilizing the school-based behavioral health liaison position to help with that. I do know that there are some providers that are focusing their proposals on kids because of that increased need, but I don't have that list. I can't tell you which ones are kids-based at this point.
Representative Lamar.
Thank you. One, I would love that list as soon as possible if you
Okay.
can. Thank
Okay.
you so much. But so every county gets equally one
Yes.
person?
Yeah,
So does that mean Shelby County, which has like 200,000 kids,
right.
has to rely on one person versus a smaller rural county, which only has 20,000 kids?
Right.
So the ones in the rural areas or the smaller counties get better service
Yeah.
because that one person has more capacity. Okay.
So wait, can I respond to that?
Okay. Yes.
That's our start. That's our base. Okay. So we wanted to make sure that there's one in every county and we've got that now. However, the new funding, the 6.5 million that you guys gave us last year, those funds are going to address exactly what you're saying because obviously it's out of sync. If Shelby County only gets one person throughout this process and they've got this many kids, I'm absolutely in line with what you're saying. We need to make sure that it's fair across the state, but all we had was enough funding to do one in each county. You will note as we go through this next year, more school-based liaisons will be funded through other dollars, not just the base funding that we got.
Representative Lamar.
Thank you. I
You're
appreciate
welcome.
that. Is there like a formula we have in order to determine the person to child capacity? Because even then, I think
Mhm.
that Shelby County, for example, will
Mhm.
probably need about 100
Mhm.
versus, a smaller
Mhm.
county maybe need 10 or 20
Yeah.
or something to that capacity. Is there
Yeah.
like a formula we can determine one person per number of
We're
kids?
looking at kids. Yeah, we're looking at number of kids in each county. But I also want to say it's not just that only one person does help for the kids. It's that liaison that hooks them up to the services and people that are already funded in the county. So that one person is not the only person working with kids in Shelby County. You've got Case Management, Inc., and you've got Alliance, and you've got some other providers that are actually funded and have case managers and therapists that work with kids. So it's not just one person. I'm just saying that for the liaison, that's the person that's linking people into services already funded. That's who we've got. Mhm.
My last question is, and I'm asking these questions, I do think they're important.
Yes,
Is there also any collaboration with the juvenile court system?
absolutely.
And I know that we're, especially in Shelby, we have a lot of issues with our juvenile
Yes.
court.
Yeah.
And some of those kids shouldn't be in jail.
Mhm.
But could you kind of talk and explain what some of the programs or initiatives you have with juvenile court?
We absolutely can. I want to say one thing. I worked in Shelby County. When I first got out of college, I worked at Midtown Mental Health Center and then Catholic Charities. So I'm very familiar and know a lot about that juvenile court. We are doing so much in combination, partnership, collaboration with juvenile courts across the state, not just Shelby County. And I'll ask Deputy Commissioner Yancey, because he oversees that work, to give you a little bit more specific on that.
Yeah, Representative, it's a timely question. We're actually meeting with the Council of Family and Juvenile Court Judges, I think this Friday.
Mhm.
We're doing a couple of things related to the juvenile justice population, one of which is, I think, with 6 or 7 providers across the state to work children and youth prior to adjudication. So once they're referred to the court, the judge will say, hey, this charge may not necessitate it going formal. Let's refer to this provider who's doing an evidence-based program. We've had a lot of success with that. We've seen data that supports that the majority of these children are not going forward in the court process. They're staying at home with their parents, which is really, really important. The other thing with the juvenile courts that we're doing is around safe baby courts in partnership with the Department of Children's Services and the AOC. And we're continuing to expand safe baby courts. That also is seeing or producing similar outcomes related to permanency and stability within the home for that early childhood population. So I know beyond those two programs, that many of our providers have longstanding partnerships with local juvenile courts. They work closely with the judges. Many of them have staff housed at the juvenile courts. So we know it's a growing need, and we're committed to doing more.
Next on my list is Representative Ogles, and I would ask, we are getting short on time, so if we could be brief with our questions and our answers, that would be helpful. Representative Ogles.
Thank you, Madam Chair. Thank you, Commissioner. Going back to 2019, pre-pandemic, like everything we talked about across multiple departments was opioid epidemic, like over and over. The only word I heard up here more than opioid was recidivism, which I can finally say. What's happened with that? Are we still having an epidemic? So much of our programming, so much of our funding, so much of what I heard you talk about and multiple other commissioners talk about were involved with opioids, over prescription of those, the programming, the reimbursement rates that doctors were telling me that they had to provide these during treatment at facilities, because if they got a bad score on somebody's experience, it would hurt the reimbursement. So they were actually being coached and told, they have to be happy when they leave. Well, how do you make somebody happy? Well, you give them a pill. So there was a kind of problem across the board, I would say, that I think many departments recognized. What is still going on with that? And then my next question, two-part question, is with your data, you said you're data-driven, the anxiety and depression numbers seem to be very, very high.
Yeah.
We had a spike in that. Are we going to over-prescribe something to treat anxiety and depression? And then are we going to come back in 2 and 3 years and say we've got a new epidemic because everybody was depressed? We over-prescribed this pill, and now we've got a whole nother group that we're going to spend the next 5 years trying to treat and wean off over-prescribed medications. Thank you.
Those are two really major big questions. The first one, the opioid epidemic and where we are. We really have done a great job in this state related to lowering prescribed opioids, so pain pills. And you can see that in the Department of Health's data. It's really, really gone down low. So you ask yourself, why then are we having more overdoses? Why did we get a 45% increase in overdoses? And that goes to the second part of this response. Fentanyl-laced drugs on the streets are being proliferated. We just did a big news conference that with TBI and Department of Health saying, look, guys, these drugs are bad. They're laced with fentanyl that is deadly. It's not just a straight pain pill that you're taking. It looks like the pain pill that you're taking. So we're urging citizens to not take a drug off the street. You do not know what it is, even if it looks exactly like what your pain pill looked like. So I can tell you that is what we're seeing right now. To your first question, does that respond appropriately? To your second question, are we going to overprescribe because of the increase in anxiety and depression? That really depends upon the person who's doing the evaluation of who's coming in front of them, and depends upon how they do or do not utilize medication in overseeing that patient. I don't have the data, and I'm sure my pharmacy director can get this about how prescriptions are going around anti-anxieties and antidepressants. Your question's a really good one. So I'd like to do like a trend, which I don't have with me, and sort of see what's happening. It's a very great question. Thank you.
Leader Camper.
Thank you, Madam Chair. Thank you for your presentation. I'll be short because I was really concerned about the rural recovery, and you already talked about that. I wanted to learn more about that. But secondly, I did a session with some college-age students in the student government, and they were concerned about their access to mental health and substance abuse and what they were dealing with during COVID. So can you talk to any programs or support that you're doing for that college age group?
Yes, ma'am. It is something that's near and dear to my heart. we have started a collegiate recovery program under Dr. Monty Burks, who many of y'all know. He's our Director of Faith-Based Initiatives. And we have a member of our team, he's a lifeliner that works out in the community. His name is Nathan Payne, and he really is our point person on this. And we have done trainings with colleges across the state. Deputy Commissioner Yancey has been at those trainings and spoken at those trainings. We're also creating collegiate groups on campus for students to be able to talk to other students who are in recovery and to give that support to maintaining that recovery. I'm very excited about this. And Matt, do you want to add anything to this?
Leader, I would say the data that we look at supports that if there's any age group that's been impacted by the pandemic from a behavioral health perspective is college age adults. And the commissioner's right. We are doing as much as we can to partner with colleges and universities. This Veterans Day, I was actually at Motlow State. They've started a collegiate recovery program. We also have other kind of ancillary programs related to the young adult population. We have a first episode psychosis program across the state for young adults that may be experiencing their first psychotic break. So we know it's a population that we have to keep our focus on just because there's such an immense need. And we do look forward to doing more with all colleges and universities. I think we have an event at University of Tennessee, Knoxville next month. We'd love to partner with every college and university in the state around collegiate recovery and connecting their students to treatment and recovery support services.
Leader Camper, follow up.
Yes, ma'am. Thank you very much. I appreciate that. I think we need to probably increase our funding outside of our COVID dollars and really put some funding into those programs. I think it's much needed. But also for young people who have aged out of foster care and, some of the programming that they may need. And this whole group of young people that we've categorized as disconnected, they're not connected to a college, they're not connected to something that we can track. But, if we're able to assess where they may be and try to bring them in, maybe do some marketing toward that group so they'll know that there's a place for them too. I think we should maybe consider that, or maybe you all are and can just brief us on it, but I can get the answer later. Thank you, Madam Chair.
Representative Sparks.
Real quick, Chairman, I just want to thank this committee and your leadership for the passion and conviction. This isn't a Democrat issue or Republican issue. I heard Chairman Faison open up about his father. I've had him on a radio show back home, but he's talked about it, and appreciate Representative Freeman opening it up. Last year, I had to carry a woman to identify her daughter who had overdosed. They think it was fentanyl. And, I've seen this in my own family, the hurts and hangups. But if I could, Chairman, about 2 years ago, we put an event together in my community. I've shared this at education. We have the drug court judge, Judge Tidwell there. Monty Burks was there. Tennessee Mental Health Cooperative was there. Dr. Brian Terry, both school superintendents. Here's what came out of that whole event. We had about 110 folks in attendance. I want to read this letter from the late Dr. Gilbert. I've shared this before education. I want to share it before this committee. Here's what she said. She said, Mike, I apologize for the delay in responding. She says, thank you for reaching out. Yes, more funding for counselors would certainly help with the social emotional issues we're seeing. Another area is social workers. They're vital and many school districts are not able to fund them. She said, I also think it'd be helpful for him and other legislators to talk with school superintendents about the issues we're seeing in very young children. And this is what's important right here. The behaviors of our 6 to 9-year-olds are like nothing we have ever seen before. This is a 50-year educator that's saying this. The behavior of our 6 to 9-year-olds are like nothing we've ever seen before. They are inordinately disruptive and aggressive, and while we're bringing all of our resources into play, there's no place for these children to go to be assessed and treated. I feel very good about what the Department of Education is trying to accomplish in this area with emphasis on the whole child, and I'm hopeful that Department of Mental Health and Substance Abuse will work alongside them to help address the upper tier children who there seems to be no answers. Sadly, that school superintendent, that 50-year educator, passed away about 3 months later.
Mhm.
I know that this committee and the governor has put more resources into play. 55% of our inmates are on psychotropic drugs. Our prison budget, I'm seeing where the request is going to be an additional 60 million. 1.3 billion is what we spend on our prisons. So to me, any investment in this area, especially with the young folks, whether it's counselors, nurses,
Mhm.
social workers, to me is an investment. And I appreciate the passion that Chairman Hawk and Scotty Campbell and others that have been fighting for these issues for a long time, and the whole committee in general. But how do we do? I mean, how do we reach these young people who sadly can be those inmates that request in 10 years may not be 60 million, it may be an additional 100 million.
Mhm.
And
Yes, sir.
I'll shut up and listen. Thank you.
Yes, sir. I want to say to you, I had the privilege to meet Dr. Gilbert right after she had that larger meeting. She reached out, and Chief of Staff Thornton and I went and met with her in Murfreesboro at Trust Point with Beth Goodner, and we put together some incredible plans, which really are being enacted right now. And just to give you an idea, here's one of the enacted plans that has occurred. If you look in rural West Tennessee, we visited a community where we went to a school, and we really are hoping to see more and more of this through the plans that are coming in for us to fund, where the counselors actually at the school, they're supported and hired by the local mental health center, but the school so much was supportive of this that they created their own office out of an old office where they allowed that counselor to be stationed there. And I can also tell you that it was so wonderfully set up and so inviting and so welcoming that, like Deputy Commissioner Yancey asked for a session. I mean, he needed his own self to have a session that day. And we let him stay for about an hour, and then we went on. He's still having sessions, but not there. But anyway, he knows I'm joking with him. But no, I so resonate with this. I was one of those kids at a school that when I was growing up, really poor with an issue with my mom. I would have given anything if somebody had been there and paid attention to what was happening in my life and had reached out. So this is very close to my heart, that any kid that we can help, that we can save, not just them, but their family, because y'all have created a system, even though we don't have Medicaid expansion, what you've done allows us to take adult funds for that family. Like in my case, my mom, she could have gotten help. And the kid itself, the kid that's there, and I didn't mean itself, but the kid themselves, would have been welcome. I would have gone into that room as a young person and sat down and told that counselor, here's what's happening. So the more that we can partner, going back to that word that we talked about, that we can partner with the local schools and they allow our people that are funded through those local providers to set up shop, the more difference and change we're going to see. We're going to see major change and difference there. So I hope that responds to your question.
Thank you, Commissioner. We have one final question. I would ask, we're a little bit over time. Representative Lynn, if you would close us out, please.
Oh, thank you. And
Yes.
honestly, you may just want to, it's fine if you want to come and talk to me in my office.
Mhm.
I was just worried, I wanted to ask about a couple of things.
Mhm.
Where are we with training police officers to deal with mental health situations? I know some counties and cities have trained more officers than others. And I know that like NAMI, they try to train people,
Right.
but that is so important. When someone's in a
Mhm.
mental health crisis,
Mhm.
it is so important that we don't add to their trauma, and do have someone who's trained when they're taking them in. And then my next question is statement first. We really don't have enough psychiatrists in the state or therapists. And what I'd like to know is, are we doing anything to try to encourage and incentivize people to go into these practices and you know, if we are doing something, can we make it a point to do more? Because there really are not enough. And I hear it constantly. It is so hard to find someone. And what I'm hearing most recently is that many of the therapists will no longer take even private health insurance. Now, they will take on a sliding scale for low-income people. They will offer a sliding scale. But for people who do have, just traditional health insurance, they say, you know what, I don't take that health insurance and I just want you to pay. And that's a curiosity to me. I think the economics of it just needs to be looked at. What is going on and why are they doing that? And there's definitely reasons for that. Maybe that's for commerce and insurance or some other department, but I'm interested in learning more about the economics of that. So come talk to me. And if you want to address anything here, I'd appreciate it.
Just real quickly, CIT, absolutely, we're expanding it. Not only are we expanding it, we're looking at working with Madison County to expand. They already have a simulated classroom where they can train any sheriff, any staff member out of the sheriff's office to know how to respond. And we have worked and continue to work with NAMI to expand it. That's expanding, I can tell you that. As it relates to the shortage, we talked a little bit earlier about that. We've co-wrote with our partners at Tenncare a plan that's based on statewide input from providers and other individuals to address the workforce shortage. Psychiatrists are a huge gap, not just in this state, it's nationwide. The average age of a psychiatrist right now is around 80. And so, I mean, it tells you we need help. And so when you're looking at that, one thing to look at is, are there other ways that we could provide psychiatric services and expand scopes around other professions? Since, I mean, you can't grow psychiatrists that are not there, and we've got this huge need with the pandemic that's happened. So totally agree, and you'll be getting a report, the workforce report, when we finalize that.
I just wanted to say that I do a lot of study on this, and what I've seen is that physicians, they're often attracted to psychiatry, but it's they don't feel that there's a lot of benefit to the practice because there's not a lot of satisfaction. You don't always cure someone. You don't always see the results like a surgeon who sees results, and that's very, very satisfying. So it is hard, and so we do need to incentivize people to go into psychiatry because it is, something often that there's not a lot of great outcomes, but there's so many people who just need that help. So thank you.
Yeah, and I would say if that psychiatrist would come and work at our institutes, they'll see a lot of great outcomes with people because of the wraparound services in the community. It's a very rewarding field.
Commissioner, thank you again and your staff for not only for joining us here today, but for the work that you do every day for Tennesseans in a field that is, as has been referenced here, many of us have strong interest in and recognize that there's a lot of unmet needs, but we appreciate what is being done to close those gaps and recognizing that we're never going to live in a perfect world where everybody can get all of the services that they need, but we certainly appreciate the fact that you are doing your best to stretch our resources to meet that. So we thank you, and we would ask our Tenncare folks who are hopefully in the building to begin making their way to the table. Thank you.
Thank you.
If we could have our Tenncare folks, please. I'm sorry, I thought you guys had heard me. We're going to try and move and get started. Thank you. I think it goes without saying we're appreciative of the time that you all are taking to be here with us today. We know it's there doesn't seem to be much downtime anytime anymore, but we know this is an incredibly busy time, even more so than usual, with budgets being prepared and all of those things. So we thank you for being here to bring us up to date. Again, a reminder, we're focusing on federal funding dollars that have come in that we would not have known about when we did when we did the budget for this current year. So with that, we'll ask you to get underway with your presentation. I feel like we're going to have a lot of questions. So it asks people to be attentive so that we don't ask questions that have already been answered and that we can get to everyone's questions in our allotted time. So thank you.
Thank you very much, Chairman Hazelwood, members. It's good to be with you this morning. My name is Stephen Smith. I serve as the Director of Tenncare, and with me today I have William Aaron, our Chief Operating Officer, and Zane Seals is our Chief Financial Officer. We very much appreciate the opportunity to be with you this morning to give you all a status update and offer some clarity on the federal funding that we have received throughout the pandemic. And we do have some slides to help with that. We're going to go through these very quickly because we want to leave plenty of time for questions and comments that you all have. So at the beginning of the pandemic, the federal government enacted legislation that provided an additional 6.2% match for all Medicaid programs. So that increased Tennessee's match from about 65% to 71%. And unlike a lot of or actually most of the federal relief that you all have been talking about and will talk about, this was not provided to us in the form of a grant or for any one specific purpose within Medicaid. Rather, it's designed primarily to address the increased costs that the Medicaid programs are facing throughout the country. And that is due primarily to increased enrollment and also testing and treatment due to COVID. But it also is designed to help states that have severe budget issues. And that makes sense because if a state has to make drastic budget cuts, it's almost inevitable that those cuts will have to come from the Medicaid program since that makes up such a large portion of the state budget. We know that the enhanced federal funding will continue through any quarter in which the public health emergency is in effect. So this next slide gives you all a picture of where the overwhelming majority of the increased costs come from, and that is due to the increased enrollment. And the enrollment increase is due primarily to the fact that during the emergency, there is a maintenance of effort provision that has been put in place by the federal government. And what that means is we are not able to remove anyone from the Medicaid rolls, regardless of their eligibility. And you can see the result of that on the screen. So to date, we have increased our Tenncare enrollment by about 200,000 people. That's about 14%. Our latest projections show our best projections, we believe that the federal emergency will end in March of 2022. So you can see that we will peak in enrollment in March of 2022. And then you'll see a gradual decline as we go through that redetermination process. And that is a process that is required by both federal and state law. And one important thing to note here is that our increased costs, they don't just go away once the emergency ends and once the enhanced federal matching dollars come in. That is going to be a gradual decrease. And that's why it's important for us to have dollars banked so that we can account for those costs as our enrollment gradually declines post-pandemic, post-emergency. Now, there's a caveat to this, of course, and that is the federal legislation that's being discussed right now. A portion of that discussion revolves around Medicaid, revolves around the maintenance of effort provision, and also the enhanced federal funding. So we're closely monitoring all of that. but it's very possible we are going to have to revise our projections based on whatever it is that they do at the federal level. So when we think about the estimated cost from this, we really look at it over the course of the entire pandemic, the entire emergency. And that's because these costs, they don't come in neat little packages around the fiscal years. So here you can see our estimated cost from enrollment broken down by fiscal year. And you will note that our largest cost estimates are incurred in FY22. So that is this current fiscal year. Next, you'll see our estimated costs for testing and treatment. So about a total of $500 million through FY22. And one note here for FY23 and beyond, we are incorporating our testing and treatment costs into our normal recurring budget. So you won't see a carve out for that going forward. Here, you will see the estimated impact of the enhanced federal matching dollars. So these are our best estimates with the information that we have today. You will note that based on our projection of the emergency going through March of 2022, we believe that we will have an estimated total of about $1.22 billion from the enhanced federal match. And then on this slide, from a fiscal responsibility and budget perspective, this is the slide you probably want to pay close attention to because it estimates our total increased costs from this emergency, as well as the increased federal funding to account for those costs. And what you will see here, the bottom line, is that we are currently in good financial shape to meet our obligations with our enhanced federal matching dollars exceeding the estimated state cost to account for the increased enrollment as well as the testing and treatment. So that completes our prepared remarks. Madam Chairman, I know that was a lot of information prepared, presented in a very condensed manner. We're happy to answer any questions that you all have.
Thank you so much, Director. And just quickly before we get into our other questions, if on slide 5, if you could go back, I think you talked about the fact that these ongoing costs would be incorporated into future budgets. There would not be a line item, so to speak. And can you tell me when that begins again?
So that would be starting in FY23. So that would start July of 22. So when we present our budget to you for FY23, those costs will be incorporated in our overall trend number.
All right. Thank you for that clarification. I just missed that as you were walking through. The first on my list, I have Chairman Todd.
Thank you, Chair Lady. Appreciate you being here, and thank you for what you do for those in our communities that need it the most. I understand that Tenncare has provided about $4.3 million in relief payments to dentists throughout the state. Has Tenncare provided similar relief payments to other service providers other than dentists?
Yes, sir, we have. And on the information that we provided to the committee, that was tied to a specific fiscal year, and that's why you see dentists listed there. But early on, we also provided relief payments to home and community-based service providers. Those are direct service providers, behavioral health providers, primary care, and then, as you mentioned, dentist. And there were also dollars that were tied to the nursing facility assessment that went to nursing facilities, went directly to them. And then there are also dollars that are tied to the hospital assessment that are currently sitting in the Hospital Assessment Trust Fund. We are working with the Hospital Association to distribute those funds.
Okay, thank you. Do you think those relief payments have helped keep these dentists in business during this time frame?
Well, I certainly believe that they were needed and they were very helpful to those providers, specifically for dentists. Remember when in FY20 when the pandemic first hit, dentist offices were closed, and so their revenue was down to zero. And so it provided a real help to them to kind of sustain them.
Okay, I would have thought so. Were any of the relief funds provided to local health departments, either for services provided at the dental clinics or through the dental grant programs with the Department of Health?
We did not, so specifically on the provider relief, we did not have any funds flow directly from Tenncare to the health departments. However, the health departments would have received dollars from other sources.
Okay. During the pandemic, I think Tenncare renegotiated capitation rates for the MCOs due to the limited services and the types of services enrollees were receiving during that time. Was Tenncare able to do something similar with DentQuest? And if so, what were the savings realized from that procedure?
Yeah, I'll speak to the first part of that. So one thing that we said from the onset is that we wanted to ensure that our managed care organizations did not profit from this pandemic. And so we did make adjustments on those capitation payments. I think we've made 2 adjustments now, and William can talk about that. On the dental, the dental manager works differently from our MCOs in that it's not really an at-risk arrangement, and so we didn't do something similar with the dental benefits manager. But William, do you want to speak more specifically to that?
Yep. Thank you. Thank you, Director. Yeah. And it's an excellent question. It goes to, as you just heard the Director mention, that we pay our big MCOs differently than we pay DentaQuest, for example. I don't know about you all, but because during the pandemic, I wasn't driving as much, my car insurance company sent me a refund check, right? Which was a nice surprise, right? I wasn't expecting that. I didn't ask for it. But I didn't drive nearly as many miles. And apparently that wasn't just about me. It was the folks they were covering. Similarly, with our MCOs, we paid when we set the capitation rates, as you mentioned, sir, that there are a certain level of service that we expect is going to be delivered. Well, obviously that didn't happen. And as you heard Stephen mention, we wanted to make sure that the MCOs basically didn't make inappropriate levels of profit because we were paying them for this level of service. And what was actually being delivered in the pandemic was this level of service. Right? It's like an insurance premium that we all pay. That's what those cap rates are. The dental benefits manager is structured differently, and that is more fee for service. So the only way that those dollars get paid is if a Tenncare member goes to the dentist, gets a service, and then that comes back and we pay that. So it's not prepaid in the same way.
And the very last part of that was, what kind of savings did you see from that?
We'd have to, I don't have that right at my fingertips. We have seen a number of savings. Yeah, Zane, have you got it?
On the MCOs, it was just a little. I'm sorry, can you hear me? Yes. Yeah, on the MCOs, it was just a little over $300 million.
Okay. And your name, sir?
Zane Sills,
Thank
Chief Financial Officer.
All right. Thank you, Madam Chair.
Thank you. Representative Campbell.
Thank you, Madam Chairman. My question involves Tenncare indicating that you had requested the enhanced federal Medicaid assistance percentage dollars be increased to hospitals with their payments. And since Tenncare cannot explore this usage of funds as determined by CMS, what other avenues is Tenncare pursuing to provide support funding to hospitals?
Yeah, thank you for the question. So I believe you're referring to, we worked with the THA early on to submit an emergency waiver request to CMS that would have driven some dollars out to the hospitals. And it was related to quality plans and well, it was related to preparation and all the work that the hospitals were doing around the pandemic. Unfortunately, after many, many months, CMS declined to approve that. And so now we're pivoting and we're working with the hospitals to try to come up with another plan that we could submit to CMS, and that would be tied to a directed payment. We think that our chances will be better with this particular proposal. We haven't finalized that yet, but we're in discussions with the Hospital Association to push those dollars out.
Thank you. Thank you, Madam Chair.
And I guess just a sort of a follow-up to that, while, CMS declined the first proposal, we're hopeful that they will approve the second. Will those dollars be retroactive? And assuming the worst case scenario, if those dollars are not approved, then what plans do we have to, because I know hospitals have taken a very long and very direct hit during all of this COVID, not only because of the COVID patients, but because having a number of COVID patients has deterred them from being able to provide services that would normally be more revenue producing on that side. So what sort of, I guess, safety net do we have for our hospitals in this case, or what are our plans to try and ensure that they are at least somewhat fairly compensated for the costs that they've incurred?
Yes, thank you for that question. So we do think, I mean, it is true that they did not, the original proposal that we submitted to CMS and working with THA, it was a pretty unique proposal. What we're working on now is more of your traditional type request, and so we're pretty confident that this is something that will be approved. In terms of the retroactivity, I'll defer to William to answer that.
Right. So, Chairman, the way that this would work if it's approved is that once approved, we could pay dollars out. And it's not retroactive in the sense of it's not a rate increase that would go back into effect, but it would just be dollars that move out to hospitals once it's in effect. The hospital thing is a little different, right? Because nothing's easy with Medicaid. And the dollars that would fund that are in the Hospital Assessment Trust Fund that have built up because of the enhanced FMAP. So what would happen is that we would have those dollars going forward. The feds would not give us permission to make it retroactive.
And what happens to those dollars what happens to those unexpended dollars?
Well, that's part of what we're working with the THA now in conversations about how to expend those dollars. If they remain unexpended for whatever reason, they sit in the trust fund until the THA and Tenncare and everyone can agree on how those get expended.
Those dollars will not be there would not be a clawback to the feds on those dollars.
Oh, no, man. Those are our dollars, if you will.
The very worst case scenario there, if for some reason the federal government just refused to approve those directed payments, at the very worst, there would be right now there's about 180 million in that trust fund that could be dispersed to the hospitals. But of course, that's not the ideal situation because we want to draw down the federal dollars.
Right. Thank you, and pardon me for taking us down a rabbit trail. Chairman Faison, you're next.
Thank you, Madam Chair. Good morning, y'all. Good to see you. During the Tenncare's budget hearing for the first week of November, it was mentioned that the hospital assessment was started during the Great Recession. It was news for a lot of us. Just a couple questions on that. How long, if I can, Madam Chair Lady, just a couple questions. How long does Tenncare foresee the hospital nursing home EMS assessments continuing?
So specifically, you're asking about the nursing home and the EMS assessment.
Mm-hmm.
Well, those are in place today. They're important mechanisms to operate our program. They benefit the nursing facilities. They benefit the EMS system. If those were to go away, of course, we would have to find a way to account for those dollars within our state budget. And so it's really a question of with the administration and the General Assembly, would it be appropriate to kind of plug that gap with state dollars?
Well, that was part of my question. Are there any budget plans in place to transition away from these assessments? Is there any talks with Tenncare thinking in amongst y'all? Is there something we can do to move away from these assessments?
We have not had any conversations with the nursing facilities or EMS on reducing or eliminating those assessments. There certainly have been conversations about opportunities for increased funding for those particular groups. But there have not been any substantive conversations about reducing or eliminating those assessments.
Okay. And finally, if the assessments do not continue, will Tenncare cut the services paid through the assessments?
If the assessments did not continue, it's just important to note that those assessments are tied to very specific items in the budget. And so if we didn't have those funds, it would impact those services for those providers.
Okay. Thank you. Thank you, Madam Chair.
Thank you, Chairman Faison. Chairman Whitson.
Thank you, Madam Chairman. Good morning, team, and I appreciate all y'all's help over the past year as we work through the Katie Beckett program. Again, it helped getting that developed. You talked briefly about increased costs and hospitalization in your plan. I have a few questions dealing with nursing home assessments and also increased costs to the hospitals, particularly when it comes to the impact of uncompensated care to our hospitals during the pandemic. And you mentioned your plan. Are y'all addressing that also for the uncompensated care?
Well, the federal relief dollars, they don't specifically tie to uncompensated care. They're really, again, designed to just help us to meet the costs that are associated with providing Medicaid benefits to Medicaid members. Uncompensated care is always an issue that we deal with, whether it's pre-pandemic or post-pandemic. And there actually are some discussions right now happening at the federal level, which could have a big impact on uncompensated care and the dollars that we could pay to hospitals for uncompensated care. So we're very concerned about that, and we're working with the hospitals to try to better understand that provision. We're working with our federal representatives as well and a lot of states are, to kind of push back against that particular provision, because it would result in a hit to our hospitals, because it would decrease the amount of dollars that we could claim for uncompensated care. So it's certainly something that's on our radar.
Okay, great. What is the plan for transitioning individuals who qualify for Tenncare now during the pandemic, and once the enrollment requirements have ceased during the pandemic and these individuals are no longer eligible? What is your plan to help those folks?
Well, so we will go through that redetermination process, and one thing that I certainly want to say in the record is we want every individual that is eligible for Medicaid and that wants Medicaid to stay enrolled. But we have to go through a process. And I've always said that there's a dual responsibility here. There's a responsibility on the Tenncare member to ensure that he or she provides us all of the information that we request and that we need to ensure that that individual is in fact eligible. And then there is a responsibility on the part of Tenncare to make sure that that process is as user-friendly and easy as possible. And so that's what we are really working on. And we've got a new state-of-the-art eligibility system that is in place today that wasn't in place prior. And so that does make it a lot easier for our members to stay up to date and to get information and to respond. And we're also going to have an all-out effort to get awareness out there that when the emergency ends, when redetermination starts, we will work with our sister agencies, we will work with our advocacy partners to get that word out there so that people know that they need to respond to their mail, they need to respond to their email, to their text, whatever source of communication that they prefer, that they've chosen. We want to make sure that we get that word out and that they respond so that we can maintain that eligibility if the member is eligible. In terms of members that go through that eligibility process and then it's determined that they are not eligible, I do have our Director of Member Services that is here that can probably speak better to this, but there are things that we have to do to determine if they are eligible for other services. So for example, maybe they are eligible to receive a subsidy on the exchange. We would provide information relative to that opportunity. So happy to have her come up here if you wanted to get into more detail on that, but that's.
Oh, well, you could,
Chairman Whitson.
I don't think we need for her to come up. I think that covered it, but we will follow up offline later on.
Right.
Also got another question.
Go ahead.
Thank you, Madam Chairman. Has Tenncare begun drawing provider relief payments for nursing home facilities through the enhanced federal matching program for nursing homes?
We did. So we did draw down additional federal matching dollars for nursing facilities, and those are dollars that are tied to the nursing facility assessment. And then we worked with the THCA to push those dollars out to the facilities.
One more
Chairman
question.
Whitson.
Okay, thank you. And I know you went into the cost increase associated with the pandemic. My specific question is to what extent does Tenncare estimate increased COVID-related costs is due to the suspension of re-verifications versus the increased costs associated specifically with COVID-related care, such as longer hospital stays, more expensive equipment, and supplies?
Yes, well, we would estimate and project that the overwhelming majority of the increased cost is due to the increased enrollment. It's not due to the testing and treatment. That is a portion of the cost, but the overwhelming increase is due to the increased enrollment.
Okay. Thank you, Madam Chairman.
And as a follow-up to that, the more I read about the long-term effects of COVID, the more frightening it gets with things that we aren't even aware of, that, organ damage and things that might not show up for some period of time. So are we, I guess, making any sort of allowances for the ongoing long-term effects of COVID on our healthcare costs going forward?
Well, one thing we are doing, as I mentioned before, is we are incorporating the what we believe the testing and treatment costs will be. We're incorporating that into our normal budget, so that'll show up in trend. And then every year we monitor that. We monitor the costs, and so we're going to see in the out years if that impact does occur, and then we will have to come back and make adjustments based on that. But it's certainly true that we could see that, but also I think it's also true that we will see some decrease in the overall testing and treatment cost as we get through this pandemic. So potentially it kind of offsets.
We can hope.
Yeah.
Chairman Hawk, you're next on my list.
Thank you, Madam Chair, and Director Smith, thank you and your team for being here as well. I appreciate that. In our prior budget hearing with Mental Health and Substance Abuse Services, we discussed the partnership between our MCOs, Tenncare, and our provider networks out there. And I'm glad that they deem it as a partnership. Sometimes I see it as a tense partnership, and there is a push and pull and tug and whatever adjectives you want to use and verbs you want to use on that, but that certainly goes on, and I appreciate your awareness of that, and I'm going to continue to advocate for the provider networks out there. I want to talk a little bit about the Choices program and some of what we've seen there with our home and community-based services, and I appreciate the potential for some federal dollars that are incoming over the next budget year and over the next couple of years in particular, but I'm concerned about the recurring nature of those dollars and the long-term availability of those dollars. Can you talk about what we're doing to help our home and community-based service providers remain viable? Again, going back to that staffing and the workforce that they've got to keep in place.
Yeah, absolutely. Thank you for the comments and the question. So as you mentioned, through the federal ARP dollars, we are able to kind of kickstart some of the priorities that we actually put in place for the FY21 budget. And then, of course, the pandemic hit and we had to make reductions. So the big piece of that, two big pieces. One was to remove 2,000 people off of our waiting list, people seeking services through the ECF Choices program. These are individuals with intellectual and developmental disabilities. And then the second piece was that kind of that workforce development that you just identified, which would provide increases in wages for our direct service providers. And so last year, you all made a significant investment for the providers that work with our sister agency, DIDD. And so for this upcoming fiscal year, you will see that we are asking for dollars that would address the Tenncare providers in the same way, and also address the waiting list. But the good thing, and so that will fund it on a recurring basis. The good thing, though, about the federal dollars that are available is it allows us to kind of kickstart that immediately, and we can, in effect, buy back the state dollars with the federal dollars. And so, but we want to make certain that we are responsible with our budget. And so that's why when we come to you and we present our FY23 budget, you will see those items in there as a recurring item. But we'll be able to use federal dollars for the first 2 years and 3/4, I think is what it is.
Chairman Hawk.
Thank you, Madam Chair. And hopefully that will get at least a little breathing room for some of our providers to understand that the intention is to go on a permanent increase. So to make those funding sources permanent. So thank you very much for that. It could have been stated in our prior budget hearing as well, but I think it bears to think outside the box and talk about getting folks into these workforce, into this particular workforce, and the opportunities that we've got for training through our TCATs, our technology centers, and our community colleges, and anything that we can do to partner. And again, if we can come together as MCOs, our Tenncare, and our provider networks to work and partner on getting folks into the workforce to stabilize, I think there's great value in that.
Yeah, absolutely agree. And that's one of the really exciting things about going back to the ECF Choices program is that we have a large percentage of those individuals that are able to fully participate in the community and also have full employment. And that's really exciting. We exceed the national average. We've seen great success with that program.
Final question.
Chairman Hawk.
Thank you, Madam Chair. Tell me again, as we're looking at the Choices program, can we talk a little bit about waiting lists for choices?
Mm-hmm.
And also, does the Commission on Aging and Disabilities have wait lists for their options program? You may or may not have direct knowledge of that, but can we talk a little bit about wait lists on these programs?
Yeah. So I'll give high level, and then Patty Killingsworth is here if you want more detail, and she can speak to it. But in general terms, we have about a 4,000 person wait list for the ECF Choices program, but not all of those are currently seeking services. So of those seeking services, I think it's about 3,700. And so with this plan through the ARP dollars and then what you'll see us propose in our budget, that will take about 2,000 off of that list. So that's really exciting. I believe there is a wait list for the options program. We don't run the options program, as you mentioned. There is a wait list for the options program. We're fully supportive of the options program because we can actually serve people through the options program, and potentially those individuals will not need to come into the Medicaid program, which is a benefit for that individual. It's also a benefit to the state from a budget perspective. If you can serve those individuals earlier through the options program, and so they may not need to come into Medicaid.
And again, on the Choices program, and Director, you and I have had some conversation. I've had some conversation with other members of your staff because and I know there's different Choices programs, and I may, in my ignorance, be getting some of these things confused and convoluted. But I know that we have people in nursing homes who are, some are seeking to get out of that kind of environment, COVID-driven or otherwise, back in their homes. Then we have a list of people who aren't in nursing homes, but who just want to avoid that and are on the list for Choices programs in order to avoid, ever going into the nursing home. So help me understand, is there a priority there? if we're looking at a wait list, if we have a wait list and on that wait list, we have somebody already in a facility that's perhaps wanting to get out, and the situations that I'm being contacted about, some of them are feeling a little bit pushed and that they may or may not have adequate home care. But be that as it may, if you have someone in the nursing home you're looking to move out of there to the Choices program at home, or you have somebody waitlisted to be on the program to avoid entry into the nursing home, is there a priority given to one or the other?
There certainly is a process. What I'd like to do, Chairman, with your permission, is bring Patty Killingsworth up, because she can speak directly to all the ins and outs of what that process is. Would that be okay with you?
That's fine. Thank you. And please have a seat. And for the record, just state your name and title, please.
Thank you. Oops. Thank you, Madam Chair. Patty Killingsworth. I'm the Chief of Long-Term Services and Supports with Tenncare. Really appreciate this line of discussion because it is incredibly important. If a person is in a nursing home and wants to move to the community, we will absolutely work with them to help make that happen. Just for a little bit of clarification as it relates to the multiple choices program. So the original choices program, which launched in 2010, is for older adults and adults with physical disabilities. Employment and community first choices. The second choices program is for individuals with intellectual and developmental disabilities. The original choices program does not have a waiting list and has not, with a minor exception shortly after its implementation. It is waiting list free, and we've been able to serve all of the people who need services in that program. So anyone who wants to move out of an institution, we can work with them to help them get community-based services in place. In their own home, in other kinds of alternative community living arrangements, there's an array of services available. In the Employment and Community First Choices program, as Director Smith talked about, there is a waiting list of about 4,000 people. And with the 2,000 slots that we are going to begin filling using the ARP dollars that are specifically for home and community-based services, we are going to prioritize those people who've been on the waiting list the longest. We do believe those are the people who are most at risk of being placed in an institution just by virtue of how long they've waited for supports. Some of them actually were on the waiting list that the Department of Intellectual and Developmental Disabilities maintained before the Choices program launched. So we want to serve those individuals first. But we certainly would and do prioritize opportunities to help keep people out of institutions and in community. That's really what all of these services are about, is trying to honor and provide supports where people want to receive those services.
All right, so just so I'm clear, for the Choices program that deals with in-home care with the elderly, we do not have a wait list.
That is correct.
The wait list is all related to the developmentally disabled and opportunities for employment in that community.
Yes,
All right, are there other questions for Ms. Killingsworth while we have her in front of us? Seeing none, thank you so much. Next on my list, Chairman Williams.
Thank you, gentlemen, for coming today. We talking a lot about obviously funding, but one of the challenges that was discussed earlier that I'm a little bit concerned about and wondered just for you to expound on a little bit more. But what we found is that some people are having lingering effects. If we go to fast forward to March 21 next year, when the cliff falls off, and then we start to remove 200,000 to 400,000 people from Tenncare rolls, and yet they have lingering effects as it relates to COVID symptoms or treatments, or even, we have colleagues that have issues because of vaccination. So I guess the question is there a mechanism in place where we can continue to recruit those dollars even, or do we have to leave, or do we leave those people on the rolls?
Thank you for the question. So the way that the redetermination process works, ultimately there's a determination if that member is eligible for Medicaid or not. So if the member is not eligible, then we cannot maintain enrollment in Medicaid for that individual. There may be, depending on what the federal government's going to do, there may be some opportunities for the providers to be directly reimbursed by the federal government for that treatment. But we don't know at this point if that will be the case. But from a Medicaid perspective, our hands would kind of be tied once it's determined that that member is no longer eligible for Medicaid.
Well, that's one of the concerns that I have as it relates to going forward. Whenever we do nursing home assessment or hospital bed assessment or all these assessments, they're percentages on dollars, and they're tied to actually something, right?
Mm-hmm.
Whereas these benefits, once these people are cut off, there's not 1% or 6.2% or 33.33%. It's literally all on the taxpayer at that point, as long as they're enrolled. But if they're not enrolled, there'll be a lot of Tennesseans that don't have the second tier or additional support and healthcare that they're used to expecting. So I have a really big concern that this time next year, we're going to be still long after the money's dried up at the federal level, that Tennesseans are still going to be trying to figure out how to provide healthcare to people that we've taken off the rolls. I have one other question, and it regards to other challenges other than the denial of the waiver. Do you have any other concerns about funding going forward? I guess one of the concerns I have is we're printing at the federal level. We're just printing money, right? There's no way to return it. And so we have to consume it. Are you concerned at all other than the denial of that waiver? Or is there anything in the future that gives you pause or concern, challenges?
Well, I mean, we feel like we're in a good spot right now with everything, with the information that we have today from strictly from a Medicaid program perspective. We feel like we've got the dollars available to meet our costs. However, if the emergency continues past the point where we are projecting and goes on another quarter, at some point, because of the compounding nature of the costs, having to maintain enrollment, it could make it very difficult for us to meet our obligations. So that does concern me. Again, our best projections show that we're in good shape, but it's so hard, as you all know, to predict the future at this point. That'd be my biggest concern, I think.
And related to that, what impact are you seeing, or do you expect to see, because of this influx of dollars and the inflationary cost of healthcare?
That's a great question. And Zane, I don't know if we've kind of worked with our actuaries and trying to explore that, but you want to speak to that?
Yes, thank you for the question. We are working very closely with our actuarial consultants to look at this question. There's a variety of different things going on. Certain costs in healthcare are going up, and we are seeing inflationary increases, especially in some of the institutionalization type costs. But there are other areas where the ongoing impacts of COVID have really depressed trends longer term than anybody expected, and we're still seeing some kind of sluggish rebounding of those trends. So right now, it's kind of offsetting a little bit. And so we feel like we're good, given the information we've got today. But that's something that we're continuing to evaluate and with our actuaries going forward.
Thank you. I think that's going to be a continuing concern for our budget in every aspect of it as we go forward. Chairman Baum.
Thank you, Madam Chair, and thank you all for being here to answer our questions. Tenncare is in the process of limiting the number of Medicare dual eligibility plans. What is the rationale for this?
Thank you for the question. I want to make sure that I'm careful, because that is part of our managed care organization procurement process, and we are currently under a protest. So I got to be very careful about what I say. What I will say about that particular provision is it's all about coordination of care, and this isn't just a Tenncare issue. It's really a nationwide issue where you've seen a lot of groups out there. MACPAC is one which advises the federal government and states on Medicaid policy. One of the things that is really stressed is continuity of care and coordination of care. And the way that it works is we have some individuals who are dually eligible for Medicare and Medicaid. And in some cases, you have those individuals that are being served that are Medicare eligible that are being served by providers working with plans that are not, they're not also Medicaid plans. And so what we're trying to do there is we really want to coordinate that care, because what we've seen when we talk about the evolution in the history of Tenncare, and we've seen all the successes that we've had, one of the main drivers of that success is that coordination of care. And I probably have jumbled that, and Patty's really the person that can speak more directly to this. But again, I want to be careful about specifics because we're kind of in this odd position now with the procurement. But that's kind of a high level overview. It's all about that coordination of care. And one thing I would point out is that any provider that's currently working with another managed care entity or insurer would have the opportunity to work with one of whoever ultimately ends up being contracted with us in our managed care network. They would have that opportunity to work with those groups.
Chairman Baum.
Okay, and thank you for that. I guess individuals who are eligible for both Medicare and Medicaid, we'll say Medicare and Tenncare, those individuals would receive their primary health care through Medicare. So to what extent would it be wise to limit those individuals' Medicare choices?
Well, because Medicaid actually ends up picking up a large portion of those costs. And so there's a great impact on the state budget, potentially related to those individuals. It is true that they're covered by Medicare, but it's also true that to the extent Medicare doesn't cover a particular service or is capped, then Medicaid would pick up those costs. And it really results in a large cost to the Medicaid programs. And of course, the states in Tennessee, we pay for that. So that's why it's really important for us that we have that care coordination piece, because we know when we look at the history of our trends over time, and we've been very successful there, one of the main drivers of that, again, is that coordination of care.
So it sounds like it's a trade-off between coordination and options for recipients. Anyway, I appreciate you trying to answer these questions. I know this is an area you can't say too much, but I think this is also an area that a lot of people are going to be interested in.
Understood. Thank you.
Chairman Faison.
Thank you for the indulgence, but this sparked a question for me, and I know you don't want to drill down. Maybe we need to get Ms. Killingsworth back up here. But the truth is my district, people I represent, I have a high number of people who are Medicaid, Medicare recipients, and they have the dual eligibility plan. If you decide, in whatever workshop you're in and RFPs you're in, but if you decide to get rid of that and that my people that I represent can only choose through the MCOs, how are we going to guarantee that the people I'm speaking for are getting the same kind of coverage through an MCO that they're getting through this dual eligibility program? They and my people are comfortable with that, and all of a sudden we're making this decision to sit. Couple questions. How are we going to make sure that they get the same care that they're currently getting, which is what I want to see? And number one, if they're not comfortable going with the MCO and they do have Medicare, do they not have the option to say, no, we're not going with the MCO. We want to stick with what we've got. Do they have that option with you guys?
And Patty, you may want to come up here, but what I will say here is that these individuals are working with providers, and those providers are contracted with
these individuals. Can I go back and forth with you?
Certainly.
What does that mean when you say these individuals? I'm talking my constituents.
Yes, the Tenncare member. The Tenncare
okay, all
member.
right, go ahead. Yeah.
The Tenncare member is working with a provider. They're receiving services from a provider, and that provider is contracted with the entity.
Right.
And so under under what we are talking about now is they could still work with those providers. And there's actually, we have a requirement that the MCOs, whoever those MCOs are, they have to work with those providers to try to get a contract with those same providers. And it's our expectation, and we believe overwhelming majority of cases that those MCOs will contract with those providers, which means that the Tenncare members.
I get nervous when I hear a government person saying it's our expectation. How does that look like? What are you putting this in a contract? Is this in your RFPs? I mean,
Yes.
What does that mean? This is your expectation? Because I've got real people that are really expecting a certain standard of care that they're currently getting through this dual eligibility program, and it feels like y'all are moving that around, and now they can only go through an MCO, and then you're saying it's your expectation that the MCO will still work with the dual eligibility program for Medicare recipients. So you're going to have to spell that out to me, what that means that your expectations are.
Sure. And I want to be very transparent, because I can't say 100% that I can guarantee that any MCO will contract with every single provider. But what I can say is in the RFP, I believe it's in the RFP, there are provisions that provide for a transition period where there is continuity of care with that same provider for a certain amount of time. And then there are provisions in place where we direct those MCOs to work with those providers in an attempt to negotiate a contract with those providers. But at the end of the day, I don't want to give the impression or be misconstrued, because I can't say in 100% of the cases that there would be a contract ultimately agreed to by that provider and the MCO.
That's what I was hearing you say. So it would seem like to me that the people that I represent are going to be forced to a transition thing out of what they're used to have to deal with an MCO. I'm just trying to read between the lines of what you're saying. And over the next year, it seems like to me that there's not an option. They're going to be dealing with an MCO, period. You say, just trying to read between the lines of what you're saying. You're saying they're going to contract for a transition time, and it's the whole thing's just making me a little nervous. Make me feel better about this.
Yeah, well, there would be the transition period. There's a guaranteed amount of time where that Tenncare member would be able to continue as is, and then during that time, we direct the MCOs to work with those providers in an attempt to negotiate a contract so that those services would continue and there would be no interruption at all.
So who's walking my constituents through this? You got to understand, I represent Appalachia.
Mm-hmm.
They're already a little bit nervous about anything like this going on. They don't like change. And you're talking way up here on all this level at the government level. My people specifically, who's holding their hand? We're talking senior citizens who have an expectation that they get up tomorrow and they're provided certain services because of what they've given in over their life from Medicare.
Yeah.
All right. And it feels like to me, over the next year, this is going to be snatched out from under them through some MCO that they're not familiar with. Who's taking care of them? I understand you're saying they got contracts, got this, we're working with these, who's working with my people?
Yeah. Ultimately, it's our responsibility as the Tenncare agency to work with the Tenncare member to make sure that his or her care is addressed and taken care of. That is our responsibility. And we have to work with our managed care organizations and our providers to make sure that happens. But we have to have network adequacy, and we have to ensure that by federal law, by state law, that we are providing services to our members. So ultimately, that's going to be on us. That's going to be our responsibility to communicate with those Tenncare members. Patty is here. She definitely can provide.
And I
more
have a
detail.
specific question for Patty, if I can maybe address that. From my understanding, and I've only been here around here for 11 years, so nowhere near the knowledge you have. From my understanding, this is pass-through dollars that come from the federal government as it deals with the Medicare recipients of my constituents. It's not Tenncare that we put up for a match for certain money to draw down from the federal government. This is pass-through money that the federal government through Medicare, for people who paid into Medicare all their life, this is pass-through money for them that they're given to us for these specific people in my district. So my thought is since it's not something that we put up from taxpayer dollars from Tennessee that we've matched, this is pass-through dollars. Is this really the best angle, the best use for pass-through dollars where we didn't have to put up to draw the federal funds in the first place? There's a lot of stuff there for you. So.
There's a lot in that.
Right.
And I'm going to answer that question. Let me just start with your primary concern, which is your constituents. It's my primary concern too. It's all of our primary concern. Imagine that the people among us who are older, who often have multiple chronic health conditions and who are challenged to navigate very complex insurance programs and managed care companies, are in a situation where they have two different insurance companies, some of which provide overlapping benefits. And in those two different insurance companies, they're supposed to figure out how to navigate and get their services paid for. And ultimately, the goal is a better experience for them so that they can have one company, one person helping them navigate their healthcare and not multiple different companies and programs to figure out on their own. With regard to Medicare, it is a federal insurance program, but there are costs that the state pays for those federal insurance benefits. So we pay for people who are dually eligible, who have Medicaid. We pay their premiums. We pay their co-insurance for services. And then we pay for all of the wraparound benefits that we provide that Medicare does not. The biggest one being long-term care services, right? So that's the biggest expenditure. 94% of the people who are in nursing homes today in Tennessee that we, Tenncare, are paying for are dually eligible. How Medicare administers its benefits matters a lot to the state Medicaid program, and it certainly matters a lot to people who receive Medicaid and Medicare. If you go to the hospital because you've had an acute event, and you automatically almost leave that hospital and go to a skilled nursing facility because you have Medicare, you will end up, in all likelihood, on the Medicaid rolls for Medicaid nursing facility services once that 100-day benefit is exhausted. And by the way, we'll help pay for the 100 days. So it matters a lot to the Medicaid program, and it matters to those people. As a dual eligible individual, you always have a choice of how your Medicare benefits are administered. You can choose to not do managed care at all for your Medicare benefits.
That's what I was hoping
You
to hear.
can choose.
And how do they know that?
You can education all over the place, primarily from the federal government, but there are programs in every state that assist people who have Medicare in utilizing their Medicare benefits. So you can always choose Original Medicare. You can also choose from any Medicare Advantage, which is a managed care company who administers Medicare benefits. You can also choose from any of those that you want. And as a dual eligible, you can choose any time. You don't just get to choose once a year. You could literally every month, if you wanted to. It's not a good idea, but you could change your mind every month and go from Original Medicare to this Medicare Advantage plan to that Medicare Advantage plan. DSNPs, dual eligible special needs plans, are a special subset of Medicare Advantage plans. They were created under federal law with the explicit intent that those plans would coordinate both the Medicare and the Medicaid benefits for this really chronically ill and very vulnerable population who are disproportionately high utilizers of services in both Medicare and Medicaid. High cost, high need, and really not the quality that we would expect because of the lack of coordination that often exists. That's why DSNPs were created. In practice, what has happened is that because of the way that the contracts evolved, there are DSNPs who don't administer Medicaid benefits. So the very reason that they exist doesn't apply. They don't administer the Medicaid benefit. There's nothing for them to coordinate. They're just administering the Medicare benefit. It really is a state's choice in terms of who they're going to enter into a DSNP agreement with. And if you don't have a state contract with the state, you can't be a DSNP to administer benefits to dual eligibles. What that does is it creates, again, this sort of fragmented healthcare delivery system for very vulnerable people and leaves them trying to figure out how to put Medicare and Medicaid together, and oftentimes leads them with poor quality in places that they really don't want to receive care because there wasn't somebody to help them figure out how to get the care that they needed when they needed it. This is a policy decision that is ultimately about better quality for people, better coordination for people, and quite frankly, better costs for the state, right, too. So it's a win-win when somebody gets better care in the setting where they want to receive it, and it costs the state less money. We are not the only state to do this. We are following federal policy recommendations around integrated care for this population and really how best to align systems in order to support better outcomes, better quality, and greater cost efficiency for this population.
Well, I appreciate what you're saying. And if it is to create better outcomes, then I just want to make sure that my constituents feel like it's a better outcome. When there's a change at this level,
right,
going from the dual eligibility to an MCO, that's not meeting their expectations. So if it is going to be better, I want to see that it's spelt out and that they wake up tomorrow and they're comfortable with what's going on. And I'm just, the whole thing makes me a little nervous. But
You know they're with an MCO now, right? So if they're in a DSNP, they have an MCO. That's what a DSNP is.
Well,
it's
not
a
all
managed
more
care
with a DSNP,
organization. And so, and the Medicare benefit is the Medicare benefit, right? So no matter who administers your Medicare benefit, that's the benefit that you have. It's spelled out in federal regulation. Really important that even depending on what the outcome of the procurement is, even if that means that a plan that is a DSNP today is not a DSNP tomorrow, there will be choice available to those people about whether they want original Medicare or what DSNP they want, or if they want to choose a Medicare Advantage plan that's not a DSNP, right? Those are all options that are available to people. But as Director Smith talked about, we also have very careful continuity of care requirements so that if a person is moving between plans, and it happens a lot, they get to keep not just their same services, they get to keep their same providers for a period of time. And then there is an expectation that that period of time is really to allow time to hopefully bring that provider into the network to continue seamlessly on beyond. So, and we see that, we actually monitor that, right? So when people come into a DSNP, we look at how many of them have to change their primary care providers, how many of them have to change their specialty providers. And what we see is extraordinary continuity, because during that period of time, the health plans are generally very successful in getting those providers into the network so that people can continue to use those same providers. And that really is the goal, right? It's always about trying to make the best care for that person who's actually receiving that care.
I might challenge you a bit on that, as I have been having correspondence. It's not just in Chairman Faison's district. I would venture to say that every member in the legislature will have people who are impacted by this change. And I have letter from providers who are very concerned about their ability to provide the service under a new contract. I don't think I'm, sharing any secrets when I say Tenncare doesn't pay very well in terms of providers. If you ask most providers out there, Tenncare patients are not their revenue source. So that's an issue. And I also, from what I've seen about the plans that people are currently involved in, they're very highly rated. They're, get the 5 stars and all that and the plans. And I understand this is under, we're doing a procurement process and there's a silent period. But from what I've been able to garner about some of the potential responders to the RFP, their plans are not rated as well. And I think the big issue, I appreciate the fact that people will be given time to transition, but I've got a letter from a provider who as I said, are very concerned about whether or not they would be able to even continue to financially be feasible for them to provide. And so these people would ultimately have to transition their primary care. And as you said, these are the folks who are most vulnerable. They have multiple health issues. They are the higher user of services. So I would just encourage, we're sort of beating this dead horse and I don't mean to, but I would just encourage you to really be thoughtful as you move through this process. I think there may be some other questions that we may want to get with you on offline, but we'll move on to another topic as I still have several people on my list. Leader Camper.
Thank you, Madam Chair. Thank you, Commissioner. Good morning. It's been reported that the federal government is saying that Tenncare owes them money due to an audit that was recently released. And I'd be interested to hear, and I know you've disputed it, I understand that, but I'd be interested to know your thoughts on it. But secondly, you mentioned something about the 2023 budget. And so I'm concerned as to whether this could impact that budget. Will we have to put funding aside, an earmark to repay, or have you established some mechanism to repay? Should we have to? I'll just be interested to hear your take on it.
Sure. Thank you for the question. So I'll start off. And so you're speaking to an audit that came out from OIG at the federal level.
Yes, sir.
And this relates to certified public expenditures, claims for certified public expenditures that were made by the state of Tennessee almost 13 years ago now. So 2009 to 2014. So we're going back 2 governors' administrations. I just point that out because that's a very frustrating point for me because I don't think from a state perspective that our own comptroller would ever audit a local government and look back 12 or 13 years. It's baffling to me. But as you said, we completely dispute the findings. Over half of the findings relate to claims made by institutions for mental disease. And just to kind of give you an example of how egregious these findings are, according to OIG, they are essentially saying that our institutions, our public institutions of mental disease, had 0 claims for uncompensated care. They're giving us 0 credit. That defies all logic. It defies all reason. And we have provided more than adequate documentation to show that we've had hundreds of millions of dollars of acceptable claims. The reason, the second point, the reason why we haven't addressed it as part of our FY23 budget is because there's not a scenario where that will impact our FY23 budget. These things take a long time to resolve. We've said that we are going to fight this all the way. One positive is that OIG does not make the final determination. They submit that to CMS, and then we engage with CMS about any potential payback. We feel much better about our conversations with CMS than we do with our conversations with OIG because CMS actually understands these issues. But that's why we weren't avoiding it. It's just, it's not going to have an impact on our FY23 budget.
Okay, thank you.
Leader Camper, you have a follow-up?
Yes, thank you, Madam Chair. Thank you for that answer. I appreciate, how this may make you feel with respect to them reaching back that far and the claims that you believe that our state comptroller would or wouldn't do. But I do believe that there is a reason and purpose for auditing, and that's just something that we do. And in state government, I believe that our constituency expect us to have these audits and expect us to respond to these audits. So I don't think that you're taking it lightly or anything like that, but I do feel that should it prevail after your continued dialogue and discussion and back and forth with CMS, that the state need to have a plan to repay the funds. And I know we have a healthy reserve account, and I was just wondering, were you thinking through that part of it so that we're prepared for it should we have to return or whatever the agreed upon amount might be? It may not be the 700 million, it may end up being 300 million, but we would still owe that back, which means there will be an impact somewhere, some other place down the line, maybe with services. I don't know. I know that we're operating under the block grant now. And so there's this belief that under that system, we're going to save some money. And we were believing that the savings would go back into the programming, we can expand services, and we can do a lot of things, add more services. But we may end up in a situation where we might think about earmarking those to repay. So I was just curious about, what the strategic long-term vision is to try to repay this should we have to. So that we're thinking about it now. And I understand the dispute. I understand it's been years ago, but if it's found to be valid, we have to have a plan and a strategy. And I would just kind of trying to get your sense on that.
Yeah.
Thank you, Madam Chair.
Understood and appreciate those comments. One thing that I would say is that at the end of the day, if it is determined that we have to pay back funds, that would be spread out over a long period of time, because you got to think about the audit period itself was 2009 to 2014. So there would not be an expectation from the federal government that we would, do a lump sum. It would have to be spread out over time. But I got to reiterate that we do dispute the findings. We do take it very seriously, and that's why we provided a very, very, very detailed response to the OIG audit, which you can actually find in the audit. And we look forward to making our case with CMS.
Thank you.
Leader Lamberth.
Thank you. And on a completely different topic, and one, thank you for you all being here today. The budget that you manage is literally one of the largest under the state budget itself. So we appreciate that. It's a shared program between the federal and the state. But when you look at these projections, what you presented to us today on Tenncare enrollment rapidly increasing due to some decisions by our federal counterparts in this program, and now coming back down. Also, there is kind of a natural up and down, of that program, as you guys know, over the last decade. What I've seen, it continues to increase. And then, kind of in good times when there's lots of jobs out there, it decreases. So here's my question: we constantly try to get away from siloing within state government. The Department of Labor's wages that can provide for their families. How much do you guys work with the Department of Labor and businesses out there so that these folks that are coming off the Tenncare roles can get into a job that has full benefits, full health insurance, and can actually thrive? Is there any communication between you guys and other departments within state government or with private employers to, again, truly get these folks to a point where they can thrive without government assistance?
Yeah, that's a great point, and it's something that's been a priority for this governor and this administration, encouraging departments to work together and to collaborate. And the point that you just made is a perfect one, because we do know that we have a lot of tremendous opportunities out there available for individuals to take advantage of, and so that's something that we are looking to increase that communication, increase that collaboration. But the point well taken.
Yeah. All right. Thank you, Madam Chairman. Thank you, Director. That's just something, the more you all can work towards that, I think the more benefit would be. To several of the comments here today, when we talk about making sure that folks have health insurance, the best place that an able-bodied individual who can seek full employment can get that health insurance is through an employer that provides it. We are in my district, at least, I mean, literally, it's very difficult for us to find bus drivers and folks that work in manufacturing and folks that work at jobs that pay well, but also have full benefits. And so for able-bodied Tennesseans, anything we can do to try to help them match up with those jobs that they might be appropriate for, I think would be very beneficial. So thank you.
And finally on my list, Representative Lamar.
Thank you, Chair Lady. My question probably isn't aligned with anybody else's concerns, but mine is, during this COVID-19 pandemic, did Tenncare see an increase of reproductive service from Tenncare patients, or an increase of need for OBGYN, other services? Did you see an increase of deaths or sickness from COVID-19 in pregnant patients? Can you elaborate on that?
Chairman, I have our chief medical officer here, Dr. Wu, and he would be the best person to speak to this, if that would be appropriate.
Certainly, if you would please come forward and identify yourself for the record.
Great. Good morning, everyone. Victor Wu, Chief Medical Officer. Thanks for the question, Representative Lamar. It's an area where we certainly have been really focused on maternal health and the maternal health outcomes for our members. I'll say from a data perspective, it's still a little bit early to see long-term impacts of COVID specific. If there have been any, we haven't seen any significant decreases, for example, in the overall birth rate. I think our mothers are be able to access care the way they normally would. Our OBGYNs have been able to meet those needs in the state. We're certainly going to look for and see some of the other markers, but of maternal health. The Department of Health does measure a lot of the maternal outcomes for the state as a whole. We continue to know that some of the areas of greatest opportunity are unrelated to COVID. Maternal health, mental health is an area where there needs to be continued emphasis, an area where we really begin to help support and continue to reinvest. We're really grateful and excited about having the option for postpartum care to be extended. That will begin for all pregnant women in April of this year as part of our the investment from the governor and in our Tenncare program. And so overall, we can report back to you as we continue to look at it. But I think from a need perspective, we've been able to support a lot of our moms during this period.
Representative Lamar.
Thank you. Thank you for your answer. Can any of this COVID money be used for doula services, or to create a training program for certification or a licensing program so that doulas can receive Tenncare coverage? Because what we do know is through this COVID, they provide mental, emotional, physical, and informational support for mothers. And what we've seen from the programs that have been funded, they have 100% success rates with no deaths of mothers, no deaths of children. So can we use this COVID money to do something like that?
Great question. The COVID money certainly has specific regulations around it. Licensing is an area that is not within the Tenncare space. That's a Department of Health opportunity to look at how to create licensing. But what I will mention is that all three of our plans have begun to look at opportunities around incorporating community health workers, which also includes some doula services in that to help support our Tenncare members in certain regions where there may be gaps in some of the health literacy of the members that they serve. And so our Tenncare programs have begun to look and in partnership with their managed care organizations to identify opportunities to really support some of that cultural health literacy understanding on how to navigate the OB system.
Yes, Representative Lamar, your last question.
My question is that will Tenncare reimburse doulas for their services?
Right now, doulas are currently not a provider class that is licensed and contracted with really any healthcare plan, but specifically within Tenncare as well. So we do not reimburse for doula services at this time.
Thank you all. I apologize that we have kept you over and kept our next presenters waiting, but as I think you can see, there's a lot of interest in what you all do for Tennesseans. And as Leader Lambert mentioned, it is the single largest budget item, and we are the Finance Committee. So I think it is incumbent upon us to try and better understand what you all do and how you do it and how our Tennesseans are being served through those services that you oversee. So thank you for joining us. And we will ask that the Department of Health come forward, and again, with our apologies for making you wait. And Dr. Commissioner Piercy, Commissioner Dr. Piercy, whatever the appropriate title is, please, if you would just introduce yourself and those you have with you, and then just get straight into your presentation, please.
Thank you, Madam Chair, committee members. We are proud to be here today, and with me to my right is John Webb, our Deputy of Operations. To my left is Dr. Morgan McDonald, who is our Deputy of Population Health. And because I know and over here on the other table is our Chief Medical Officer, Dr. Tim Jones. And because I know I'm between you and lunch, I will make it snappy, but in all seriousness, happy to answer any questions for as long as you need me to. So this first slide is just a pie chart of all of the different buckets, if you will. We'll go through those in more detail, so don't strain your eyes looking at that. We have received a total of 44 federal awards, totaling over $1 billion, and that is to be spent through fiscal 24. So we'll focus more on 21 and 22, but I want you to know that this has a long off-ramp, and so we will be stretching those out. This slide is the funding available to us. I apologize for a little bit of a typo there in the column. This is actually amount available, not amount spent. But the total amount available to the department is $1.173 billion. Now, we categorize that in two different buckets. The top half of that slide is the direct funds sent directly to the department, which totals just shy of $850 million. The other bottom half are indirect funds through CRF and through TEMA funds. Obviously, a lot of those cross over, and we tap into those buckets for a total of $1.173 billion in total federal funds available to the department. Now, this slide is the actual spent amount in fiscal 21 and projected through the end of fiscal 22. I will note that we have spent about $467 million of the $1.2 billion, which is about 40%. But I want to clarify why that may look low to you. Number one, this does not include things that we are awaiting federal guidance on. There are some of these federal funds that are relatively recent, awaiting federal guidance on that. Another one of these, this is through September 30th. It does not include funds that are waiting program budgets and are supposed to be coming soon. This also doesn't include those that are pending the expansion process. So don't fear, we don't lose it if we don't use it immediately. We do have some no-cost extensions available to us, and a big chunk of this, about $300 million, is ARP, which you know just came out in maybe May or June. So those are relatively recent. One of the questions that this committee asks that is really important for us is how do you prioritize this? I mean, you know, just to be honest, we've joked a lot like, well, that's a good problem to have, is to have a lot of money. But then it gets really serious really quickly. Like, that is a problem. We need to be good stewards of this, and we need to use the resources available to us. And so we want to come up or we want to execute a methodology to where we prioritize these things in an order so we can use them most efficiently. First and foremost is, what are the rules? What do we have to do? What are we told to do? That's always the first priority. But the second big bucket you'll see there is the urgent public health needs. So if the first category is what we have to do, the second category would be is what we need to do. And it's what the department needs to do. So first and foremost, there's a sub-prioritization within that category. And the first one of that being, what are the immediate needs of our citizens? Things like testing, vaccine. Those are the things that we needed first and foremost. And so that was first in that bucket. The second one is, what is the infrastructure that we need to respond to those immediate needs? Do we need newer, faster, better lab equipment? Do we need to set up new vaccine or testing sites? Do we need to purchase a software program that will make our patient flow more efficient? So that second big bucket is, what do we need to serve the constituents and the citizens of Tennessee? And then the third bucket is, what do our partners need? And so we'll talk more about that in a minute, but partners like hospitals and nursing homes and our metro health departments. So that's the prioritization that we're thinking about it in. And has worked well for us. I want to do a deep dive into, a deeper dive into 4 or 5 sort of signature programs that have accounted for the majority of these funds. one that has been not only incredibly impactful, but just quite frankly, and I don't say this because I'm a recovering hospital administrator, I can't fathom a more integral partner that has that the department or the state has had throughout the response. We've had great partners in testing and vaccine and in education and all kinds of things. But when your healthcare infrastructure collapses, and your hospital infrastructure collapses, the rest of it doesn't matter. Our hospitals have been key partners, and I wish that every state could say that. And unfortunately, they can't. But here in Tennessee, we're extremely blessed. So this hospital staffing assistance grant was pretty much a no-brainer to all of us. And it's been sort of in two phases, or it will be in two phases. And so I will describe to you what phase one was. Phase one, which we're just tailing off on the end of now, we were able to provide staffing assistance reimbursement to about 80 hospitals statewide. And so now this is separate than actually sending National Guard personnel. This was a reimbursement-based program on staffing. And as I'm sure every single one of you is very familiar, not only did we have workforce issues before, this exacerbated it. And the workforce that they had sometimes left to go what they call travel nursing because of these very exorbitant rates that they're getting. So some of them, in fact, most of them actually have less staff than they did pre-pandemic because of retirements, illnesses, saying, hey, this is hard. I can go do something else, or because they've been lured away because of this very high travel pay. So the cost to hospitals to staff, it's not like they can just say, oh, well, we just don't have enough staff today. They have to staff at certain levels to keep the doors open. And so what that forces them to do is enter into these very costly contracts. And commensurately, their reimbursement didn't change. So we used a lot of these federal funds to offset that staffing need for hospitals. So in the first round, we have already paid out about $93 million. By the time we run out what is already committed, that will be about $114 million in that first phase. I'll touch on this second phase in just a minute, but those of you familiar with the conversations with Financial Stimulus Accountability Group, there is a second phase of this that has been requested. Something else that I think we have done very well in Tennessee and I'm proud of is our testing. And that was a really, really hot topic a long time ago. And we don't talk much about testing anymore because we take it for granted. I want to remind you that Tennessee was one of the very first states and maybe the first state to have widespread available testing for everyone. And we still have one of the most robust testing programs in the nation. That was a long time ago, and so we forget about those things. But testing is one of the very key components of knowing who's infected and how to reduce the spread. We have done almost 1 million tests just at the health departments alone, and that certainly doesn't include everywhere in other medical settings. But a lot of our funds were spent on sort of what we call special testing. You remember the prison testing. You remember the nursing home testing. We did some widespread testing with the DIDD population. Again, one of the leading states in the nation to do that. And then smaller scale things like housing authorities and just different special groups, particularly vulnerable groups. We'll talk more about that in a minute, to provide tests in the past. Well, now what we're doing is ramping up the at-home testing capacity because the days of needing to go and wait in a long drive-through to get a traditional PCR test are kind of behind us. So now we're using our funds to give testing kits out our health departments. Again, no prerequisites, no cost, take home and do your test. Another one, again, that was big early on was contact tracing. This is sort of a key component to all public health when you're talking about infectious disease. Again, you'll remember very early on, people were super, super frightened about who they had been in contact with, who may have been exposed or have come into contact with someone who's been infected. And this was one of the early big buckets of funding when we used contract personnel for about 700,000 cases for contact tracing. This is a highlight of our disparities elimination work. I referenced this just a minute ago. Something else that we're very proud of, and I give credit solely to the governor for continuing to put this on our radar, is pushing the services and the access for vulnerable populations. There's a lot of ways to define vulnerable populations. One of those is uninsured and underinsured. We call that the safety net population. So just because you don't have access to health insurance or because you don't have a regular doctor, you don't need to have a lower level of services. So early on, particularly, but continuing now, supporting safety net clinics. And safety net clinics are ones that you'll sometimes hear us call community and faith-based clinics. And so supporting COVID-related costs in safety net clinics. Also in FQHCs, those are a more comprehensive approach to the underserved population, and supported them early on until they got their own direct federal funding. And then these funds also accounted for a lot of our special events, faith-based events, minority events, both for testing, vaccine, as well as some of the work to educate and to overcome some of the hesitancy in those communities. And then one that's been more recent, top of mind for a lot of folks, is our vaccination efforts. We have delivered more than 1.3 million vaccinations, and have had to put in all of the infrastructure to do that. One of the things that helped us get out of the gate a little bit faster is because we had been preparing and practicing pandemic vaccination efforts for years. We've been doing that for 4 or 5 years now through what we call our Fight Flu Tennessee. So where all across the state, and we just did this, I think it was last Tuesday, because that's when I got my flu shot, we practiced doing this all at once. And so that helped us get out of the gate faster as far as making sure we know where our sites are and what the logistics are. But as we all know, COVID vaccine is not the same as the flu vaccine in many, many respects. You have to have multiple doses. In the beginning, you had to have, there was a triage or a prioritization system. There's certain timing between the doses. So things like online scheduling and computer software programs to help us manage the logistics of that. And then my last slide is about future funding. I referenced a minute ago the second phase of the hospital staffing assistance grants. You probably heard FSAG talk about that just yesterday. That is on target to be about plus or minus another $100 million in essentially the same format related to their COVID occupancy and the burden that placed on them. But something else modeled after that program that is scheduled for the remaining funds is a similar program in nursing homes and long-term care facilities. Those guys have been very heavily impacted and have not had the benefit of some of the staffing assistance that the hospitals had. And so we are pursuing that also through the state's ARP funds and FSAG. On the public health infrastructure, I've got 4 bullet points here. The first 2 would be through the state's ARP. That is the new public health lab, as well as support of construction or renovation of our health department buildings. We do have health department buildings in all 95 counties. It is statutorily dictated that these are owned by the county. In many places, and I'm sure you've seen it in your home county, these are 40, 50 plus year old buildings. Many of them are falling into disrepair, and the counties themselves are just not able to sustain the price tag that it would cost to fix that. So those are the 2 from the infrastructure side that we're pursuing through the state ARP's funds. And then for the department's ARP funds, we're looking at workforce development, just like everybody else in pretty much every sector. We also need to bolster our workforce and then modernize our data systems. A lot of our systems did fine on a sunny day, but when they were really stressed and strained, they had difficulty performing. So modernizing that for the future. And then, as you know, this is not going anywhere anytime soon. So just making sure we're prepared not only for the next year, but the next few years as we predict and deal with future surges. Madam Chair, that closes my formal presentation. Any of us are happy to answer any questions you may have.
Thank you, Commissioner. I know it's been a very difficult and very busy year for your department. And again, we would be remiss if we didn't thank you and all of those who work with you and with your departments across the state for all the work that you've done to move us forward during this crisis. And hopefully, I'm not going to jinx it by saying anything about ends of tunnels or any of that.
Thank you, ma'am. We appreciate that.
I do have questions, beginning with Chairman Baum.
Thank you, Madam Chair. And thank you, Commissioner Piercy and your team for being here. At one time, the department requested 29 positions for the Disease and Emergency Preparedness Program, but my understanding is that those were not filled. Are those positions still needed, or are contractors doing that work?
It's a good question, Representative Baum. Those positions, the authority for those positions has expired. And so what we've done is we've utilized contract positions instead of full-time state employees to cover that need.
Okay. And when the department receives federal funding, does this come on a reimbursement basis or just in periodic lump sums?
Reimbursement basis is the general rule.
Okay. All right. Thank you.
And just a bit of a follow-up to that. In the questionnaire that you provided, and when we're talking about federal funding here, of course, there were, I believe, $25 million in state funds that were we were able to utilize federal funds rather than the state monies. So can you just help me understand what programs the federal dollars funded, and then what happened to that $25 million formerly allocated to those same programs by the state? Have we used that in some other way? Are we holding that? Do we have it still in our banking account, or and how much of those dollars have been drawn down? So just kind of help me walk through what's happened with
Yes,
the $25
ma'am.
million.
The $25 million really was payroll related. As you know, we operate out of the local health departments. Part of our folks that work there, their salaries are supported by state funds. And so we basically traded out our federal sources for what they normally do. And that's where we captured the majority of our state dollar savings. So payroll that normally would have been paid out in state funds was paid out with federal sources. As a side effect of the COVID crisis, we didn't have as many people coming into health departments. There's a lot of revenue that we generate through the health departments through billing third parties, small sliding scale insurances, or sliding scale fees. And we didn't collect that revenue. So we saved $25 million in payroll. There's a slight offset probably from where we didn't collect as much in revenue as we normally would. And whatever was remaining reverted to the general fund at the end of fiscal year 21.
Do you know approximately how much that might have been?
Just kind of an estimate, probably 5 to 6 million once we removed all that revenue. Now the department reverted a lot more than that. We probably reverted closer to 25 to 26 million, but in that particular program, we did not recognize the full 25 million in savings, in state savings.
And so aside from that 5 or 6 million, can you just briefly talk about the buckets that the other savings, the dollars that were reverted, where those monies came from?
Yeah, predominantly the savings came from the Coronavirus Relief Fund. One of the provisions of the CRF was the state could claim, health payroll, safety payroll, those types of, those types of service that provided first responding actions. And so we qualified for that, and we worked with FNA and Unified Command to kind of coordinate what we claimed on the payroll side. So the majority of the funds that were claimed were through the CRF.
Right. Thank you. Chairman Zachary.
Thank you, Madam Chair. Good morning, Commissioner. Good to see you and your team. You had referenced the department's use of spending down the 40% of the funds and really not having much issue with that. Do you anticipate needing more full-time or contractors to spend the rest of that, the allocation of that money?
You want to take that one? The answer is yes. You want to give some details on that?
Sure. I think our perspective on receiving these federal funds is we do not want to tie the state to permanent positions on non-recurring sources of funding. I think that's the philosophy of the administration, and that's something that we hold to as well. And so as we get new federal funding, and if it requires programmatic services, we would pursue contract employees.
Well, thank you, Madam Chair. And then one more question. In my 2 terms serving under Governor Haslam, I heard him say numerous times that the federal government had become an unreliable partner. I would say over the last year, we have moved into a position where the government, in some cases, it could be said the federal government has become an adversarial partner to states. And I think the CMS rule in particular is one of those. In talking to Covenant Health, UT Medical, Tenova, those who serve Knox County, they have referenced that the CMS rule would significantly cripple the ability to provide quality health care. They're already understaffed. Covenant, for example, I think 30% of their staff is not vaccinated. Many of them are nurses. If the CMS rule has not stayed this week and we move toward December 5th, they're going to lose a significant number of nurses, not to mention doctors and others. Has the department evaluated what that will look like if the CMS rule has not stayed like the OSHA rule was? If the CMS rule has not stayed, what kind of impact that's going to have on the ability for our state to provide quality care to Tennesseans?
Thank you for that very salient question, Chairman, because it's something that's weighing heavy on a lot of our providers. I did a call with the executive team of one of our large long-term care chains on Friday on this very topic, and have a call this afternoon with one of our East Tennessee hospital CEOs. Again, same topic. The difficult part, to your question about projections, each facility is a little bit different. This nursing home chain may have as much as 15% attrition. They are concerned that they may have as much. We also know from precedent from other states and other entities that it's probably going to be less than that. But still, even if it's 5%, that is going to entail closing some wings, maybe even closing facilities, disrupting patients. Same kind of thing with the hospital that I'm talking to this afternoon. So I think you're very familiar. We have significant concerns about that mandate. We do think vaccination is the right choice, but we think it should be a choice.
Thank you. Thank you, Madam Chair.
Thank you, Commissioner. Thank you for coming today. I would be remiss if I didn't follow up with Chairman Zachary's comments. In the last 5 days, I hear from constituents quite a bit, but none like I've heard in the last 10 years of service, like I've heard in the last week from healthcare providers. And as you know, my community serves 8 counties with its small regional hospital there. And 37% of the staff there is not vaccinated currently, which means if half of them choose to take a vaccine without, in order to keep their jobs and provide for their families, the other half would drastically impact 8 counties in the state and their ability to provide health care. And so this rule is one that is of great concern to all those Tennesseans who are seeking health care in our state, whether they're Tenncare patients or not. And so I guess my thoughts or questions regarding that is, do we say that we're doing a great job with vaccination because we've been practicing what it looks like for 5 years? Have we done anything, remediation plans? Do we have any idea of what the future might look like in 5 weeks if we lose 15% of our healthcare providers across the state?
Thank you, sir. That's a very fair question and one that weighs heavily on us. So I want to clarify, because I don't want to be too self-congratulatory here. We did a great job of rolling it out, providing it, making it available. But what you're describing and what we're dealing with is vaccine hesitancy. And we've got a lot of that. Mm-hmm. And there's it's very apparent in, just like everywhere, our more rural areas and with our lower income workers. Well, our lower wage workers. Well, when you talk about the nuts and bolts of what make a hospital or a long-term care facility run, it's the lower wage workers. It's all workers, but I mean, they would crumple under that. And so we have been looking at, what do we do if that happens? Part of me would like to believe that we'll figure something out. There's going to be an alternative, whether they will allow testing for that. And then the other part of me says, well, what do you do if they don't? And so we're tossing around some ideas, and it's, in fact, on our agenda internally tomorrow to talk about, what does staffing assistance look like? But then you come to this thing, all the money in the world can't buy humans. So it's a real pickle. I wish I had a good answer for you, but it's very frightening for all of us.
Well, thank you for your candor. It's frightening for us who we seek to serve our constituents. And this is a hot skillet without a mitt, for sure. But just a couple questions on the funding. Your department received $1.7 billion in funding so far as it relates to expenditure. You've only been able to spend, the deadline ended obviously before we were able to spend all that money. I think you spent about $700 million of it. So we've heard time after time during these hearings, I got this money, I don't know what to do with it, or I can't spend it. Is there are there any things that policy-wise we can do, or we can encourage others and our federal partners to do to help us claw back and be able to use that money? And if not, can we use it in a different place?
That's a great question. I'll turn to any of my colleagues for a good answer.
I think right now we're in pretty good shape of not returning federal funds at this point in time. A lot of the grants that we have extend on into fiscal year 23 and 24. We have the opportunity in a lot of those cases to get a 1-year extension, a no-cost extension, so that we can buy a little bit more time to spend the money. And then we've been coordinating with FNA. All these are estimates, right? We estimate what we're going to spend and what we're going to collect, and we've been working with FNA to make sure we have the right amount in the budget each time. We want to make a balance, because we don't want to put too much authority in because we would spend it, and we don't want to put too little in because we want our programs to have what they need. So we're trying to strike that right balance. So I think right now we're in a good position just to continue support as we kind of work through expansion processes or anything like that. The normal day-to-day of adding money to our budget, through the federal sources. That would be what we need probably.
I wasn't going to bring it up, but you did ask. The expansion process has been, the slowness of that has hurt some of our vendors. And I've gotten personal outreach from friends and providers saying, hey, we've waited for this long. So if you're asking what you can do to help, that would be one thing.
Representative Freeman.
Thank you, Madam Chair. So I'm going to ask the same question I've asked most people, and that is, what are you doing to be proactive to notify the people of Tennessee of the additional programs from this $1.7 billion? I know we recently expanded vaccine availability to 5 to 11-year-olds, and I couldn't have been more excited to take my children, but I'm sad to say I've not seen anything from the state notifying the residents of our state of this availability. What are we doing? Are we going to see a $2.5 million Brad Paisley, Governor Bill Lee ad on TV for it or something?
Sir, we're going to check your Twitter followers, because we have been posting on social media about the availability. So maybe you've got us hidden. So we, I'm just teasing. You're exactly right. We are making these types of programs known on our social media channels and through our typical, more traditional media. But going forward, when you're talking about big things, big new programs, if we've learned anything during all of this, is that government is probably the worst messenger there is. And so we need to rely on our partners. That doesn't mean we're off the hook and that we shouldn't do it. In fact, we've got the RFP just finished for our second round of market research on vaccine hesitancy. So you referenced the big, ad campaign for vaccine hesitancy that we did early on. We're going to be looking at that again. We're polling not the same people, but the same types of people, and saying, okay, now that essentially a year has passed, how has your attitude related to vaccine changed? And what are your reasons for continued hesitancy, and how can we overcome that? So I think you'll be seeing that in the coming months. But the key answer to your question is leveraging our partners and supporting them. The other thing that we've learned through this is it's not enough to say, here, XYZ clinic, use this money. Here's some money. Go tell you. They don't have the expertise and the tools to do that. So packaging up toolkits, giving them talking points, giving them content that they can use to promote those programs is going to extend our reach much further than we could do as just a state government.
Representative Freeman.
Can I ask one more question? Thanks. Second question is the OSHA guidelines that came out. I know there's a stay on that, but it's either the vaccine or testing. Is there an anticipation of the state continuing our testing facilities into a long term to meet those requirements?
Great question. It's something we were just contemplating this morning because clearly the state needs to continue offering testing. But our challenge is, how do we operationalize that into our day-to-day business? Because what is not sustainable is for a health department to have its normal operation and then to have a complete COVID operation, whether that's testing or vaccine, either on-site, outside or near site, because we're asking the same staff to run two businesses at the same time. That's not sustainable. And the fatigue is really setting in. And so plus in the context of this is not going away. This is not something that's going to go away in the next 6 months or 12 months, and then we're going to forget about it. This is something we're going to have to operationalize and put in our normal system. That's one of the reasons behind what I was referencing earlier about those self-test kits. So instead of having you come in and us have to segregate you over here because you might be infected and go do your test and then still do everything else, you can come to us for a resource. We can hand you a test kit. You can go home and do it yourself. Likewise, providing testing and other resources to community providers so they don't have to rely upon us at all. But it's a real operational challenge going forward to how to balance those two.
Leader Lamberth.
Thank you, and Commissioner, I don't have a question. I just have a comment. I want to thank you and your team for the hard work you've put in over the last 2 years. This has been a constantly moving ball as far as how to obtain victory on this pandemic. And we've all struggled with exactly how that is. I think every Tennessean has. But when you agreed to be commissioner, I don't know that you anticipated, or your team did, either one, that you would be fighting a global pandemic. So I appreciate the job you've done. Even at times when some of our colleagues, myself included, might have disagreed with this decision or that, I always knew that you guys are working very hard to do the right thing. And so I have a noon appointment I have to step out to, but I merely just wanted to say thank you before I left, because it's a really, really tough job that you guys have. And I don't know that there's any perfect answers, that some seem like they last more than a few weeks during all of this. And so we're all just trying to get through it together. And I appreciate y'all's hard work. So thank you, Commissioner.
Thank you, sir. Very much appreciate that acknowledgement. Every bit of credit goes to our field staff who's out there serving the patients every single day.
Okay, Chairman Todd.
Thank you, Chairman Baum. Commissioner, I too applaud what you guys have done and what you've been thrown into, and you've been very responsive to me when I've called with individual questions related to constituents of mine and friends of yours even. And even your assistant commissioner, who I think was just thrown into the fire very recently, he's been very responsive as well. But I'm concerned about strings that are attached to federal money. And that's always a concern that's been mentioned inadvertently already. But in one area in particular that concerns me, and I wanted to ask you about this openly. Before last year, before 2020, had you as a professional ever heard of a requirement of any government entity for reporting negative tests for any disease?
If it's okay, sir, I will ask Dr. Jones, as the head of our infectious disease and environmental, CDEP, okay, communicable disease. Thank you.
Is that working? Yeah. I would say it's very unusual, or has been, but it's becoming increasingly common. Probably the biggest was a big push by CDC to report negative hepatitis C results. One of the main reasons for that was that it's really important to know when someone has changed from negative to positive, because treatment and recommendations really depend a lot on sort of when the beginning of the infection was. And so as we're following people up and that screening has become very common, that's been very important to us. I think that's probably the biggest example.
And what time frame was that? Was that a year ago or 50 years ago?
Oh, no, 6 years maybe.
Okay.
Sir, my fellow pediatrician here just reminded me that we have to report all lead levels, even normal ones in children, essentially the same, for the same concept of we need to know when it was normal and when it was not normal. That is ongoing, has been for quite some time.
But for the flu or other diseases like that, other illnesses like that, it's unprecedented. But I'm understanding now that CMS is requiring this, and they're actually finding labs that don't comply. Now, a year ago, we had this discussion about this, and it became apparent that there was a mistake on the portal, as I understood you to tell me, that certain information was required and certain was optional. And you realized that, and I believe it got changed, but now it's changed back. All of this information, personally identifiable information, is required now on the state website, the portal that clinics have to submit test results in. These are required for negative COVID test. And I guess my question is that a very strict requirement? And I'm talking about the fine details of here from CMS, because I've read what the Assistant Commissioner sent me. It makes references to some things that aren't in this document. I don't know where to find them. And so I want to make sure that the state of Tennessee Department of Health has not overinterpreted and asked for more information that is the very minimum required. And I can understand wanting a zip code, the sex, maybe age of someone, but to know their exact name, their phone number, their address, to me is beyond the pale. There's absolutely no reason that I can come up with, and you and I have discussed this, and I wasn't convinced there was a legitimate reason out there for knowing negative COVID test. So have we interpreted, has your department interpreted the CMS intentions liberally or very conservatively?
Yes, sir. We're happy to send that standard to you, and I fully acknowledge that the CMS conditions of participation are quite onerous to dig through. We are collecting the minimally accepted or minimally required information. There does have to be personally identifiable information in there for deduplication purposes, because there are a lot of us that live in 38305, for example, zip code. There are a lot of us with the same birth year or maybe even birth date in the same zip code. So we are complying with CMS at their minimally required standard, but I'm happy to send you all the detail on that.
Okay, I would like to see what their requirement is if there's a document. And it does concern me that, if you're tracking an epidemic of any kind, knowing a zip code and some basic information without personally identifiable, I can understand that. That makes sense. That we've got an outbreak here. That to me is scientific. But knowing specific names, addresses, phone numbers, if you have them, every clinic's going to have those bits of information. And that goes into a database, and our federal government, which practically nobody in my district trusts anymore whatsoever, for a very good reason. This is a tremendous overreach, and they're doing it a lot of times with the carrot that, okay, we've got this money, but you have to comply with this. So I have a lot of folks upset over that and very concerned about that. And I would just request that the department keep this, and I'm sure you are, to the very minimum. Whatever they require, don't do anything else. That's about all we can request at this point, but it's very concerning. And I think that, along with so many other things, go to the concern you had about the hesitancy for the vaccine. There's so much about this push, this force of a vaccine to people that don't even need it. I don't need it. I have natural antibodies. And the CDC is now admitting they know of absolutely no transmission from a person with natural antibodies. Yet I know personally of transmission from vaccinated people. So those are facts that they're now finally sharing, reluctantly, I'm sure. But all those things create such a cloud over this that it creates the hesitancy. And neither of us like that. But that's where we are. And so I just ask for the department to continue fighting for the people of Tennessee and their personal liberties and their rights. I appreciate what you guys do. Thank you.
Yes, sir. Point well taken.
Representative Lamar.
Thank you, Chairman. Hey, mine's is COVID related, but not along the lines. And we talked about this in the hallway, but I just want to get on the record. What are the federal funds that we can use for doula services, and kind of talked about some of the struggles or successes that you've had around maternal health and infant mortality during the COVID-19 pandemic?
We are very blessed to have one of the preeminent maternal and child health experts to my left, Dr. Morgan McDonald.
Thank you, Commissioner. And don't acknowledge that, but thank you. So a couple of questions I think there that I want to make sure that we address. So certainly in regards to doulas and community health workers, broadly, we as a department absolutely can't recognize enough the value of community health workers and also doulas, both in the maternal and child health space as well as with COVID response, and having someone who is from a community, who knows a community, who can then really relate. As Dr. Piercy said, the government is the least trusted source of information oftentimes within communities. And so to have trusted resources in community health workers and doulas has been a tremendous asset from a COVID response perspective, but also in larger maternal and child health initiatives. We have invested some of our funding, particularly in our health disparities grant funding. We received about $38 million from CDC to address health disparities, particularly COVID related. This did have to be COVID directed, but we have used that to it really developed some of our workforce infrastructure, and particularly thinking about training for community health workers and funding community health workers. We had an RFA release not very long ago to fund community health workers. We've got ongoing meetings with several doula entities across the state, both to think about training for doulas as well as to think about sustainability plans for doulas, and recognize, as we've addressed already, with an influx of federal funds now, how do we use that in a way that is sustainable in the future, so that then if we hire and train doulas now, making sure that they have employment reimbursement going forward.
Go ahead. Thank you, Mr. Chairman. Thank you for your answer. So in clarity, could we potentially use those federal funds, because they don't have the licensing restrictions that we have, to maybe create a pilot program to provide the proof that they work, so we can continue that process of creating a licensing program for them here in the state, so we can do even more than what we're doing now?
Right. So that program evaluation is a big piece of how we're looking at funding for the next couple of years, and then really looking at what works, what doesn't work, how do we keep that momentum going. So program evaluation is a big piece of that, for sure.
So we can use those funds to do a pilot program if we wanted to?
Yes, and there's some restrictions in what we can do, but we can have a conversation about that.
Last question. How much funding is left over to be able to fund that we can use and tap into?
I'm going to have to look into the exact program budget, but I know that the 38 million was, we worked with the Health Disparities Task Force in developing that budget, and I can get you the details of that.
Okay, thank you so much. Sure. Chairman Sparks.
Thank you, Commissioner. Just wanted to, I appreciate your word choice, by the way. I like that. I've got a new daughter-in-law that started as a traveling nurse at Vanderbilt recently. But when I think you used the word sustainability, is this whole model sustainable? I mean, do you have a fear of where things are going in the future? I know I do. And with the debt and the printing of money, like Chairman Williams had mentioned, but going back on all these myriad of issues that we're facing, the nursing shortages, what else can we do? What advice would you give us to what we do to maybe fast track this or lure people into the industry? Because I mean, I've got a sister at a nursing home that literally lost everything, and it's heartbreaking to go see her. I got a mom at a nursing home. I get her ready every night, get her something to eat. The turnover, I've never seen a turnover like this. It may be up at the level of correctional officers. It's somebody new all the time. And, you know, it bothers me when I see my sister lose everything in her name, everything, you know, and she's in there with 3 other patients at $200 something a day. And I'm like, man, I'm a lawmaker, and what can I do? Probably not much, but you know, I'd like to use some choice words, but I'm not going to do that. But it really just, it burdens me, burdens my heart. Hopefully I can make an impact. And I know I've seen you speak, and we all know that you really care about these things, but you know, if you could just address sustainability and nurses, and what else we can do to retain good nurses that do care. And I think most of them do care. Thank you, ma'am.
Thank you, sir, for that. And as much as I hate to hear about the situation of your sister, there's so many Tennesseans in that very same boat. And with an aging population, I'm not sure the trajectory is going to get any better. Related to nursing workforce or just healthcare workforce in general, I really think this is a moment of reckoning for us. And it should inform us not only in the short term, but in the long term. And one of the things that I joked earlier, I'm a recovering hospital administrator. One of the things that I dealt with all the time was nursing shortages. This is not a new thing. This was a thing that we hobbled through and we limped along and we made it work, but we didn't invest the time, the money, or frankly, the political capital to set up the structure to where we could mitigate this long term. So I think that gives us two lessons going forward. Number one, there are no quick fixes. There are no Band-Aids. I mean, there are some, but they're not worth putting money into because they're not long-term solutions. We do what we have to in the short term, but there aren't any quick fixes. Trust me, if there were, we would have done them. Somebody would have found them. The second lesson I think it brings is we have to stop ignoring the problems that are today just because we can fix them today or we can get by today. And I was talking to some folks yesterday, things like respiratory therapy, things like EMS, maybe even primary care doctors. There are a lot of things that are kind of pain points right now, but we're hobbling along. We need to use that as an impetus for long-term change, and we need to start that now, not in the next pandemic.
Thank you, Dr. Foresee. Representative Ogles.
Thank you, Madam Chair. Thank you, Commissioner, and thank you for all the work y'all do. I know it's been a long road we've been on, it seems now. Earlier you spoke that you were talking to hospital administrators and giving guidance. I'm concerned a little bit in some of your messaging. You said vaccine hesitancy. I understand that, but there's a specific group within the healthcare world, workers. They're not hesitant. They just flat do not want to take the vaccination. And I got a call earlier. There's a group of doctors and nurses that are banding together, and they've asked for a religious exemption, and they're not getting good guidance. I'm hearing about a system that's discombobulated around the state where there's being boards set up, questionnaires going out. Two-part question, and then I'll make a statement first. But what recommendation is your department giving to those administrators, for one? And is that documented? Is that something we have access? Because I would like to see that. And two, what has the state done to take up the issue, and what lawyers, I'm sure we have some lawyers in the room. The question that's posed to me is, this is a direct Title VII conflict, and these doctors and nurses are going to end up in federal court suing the individual CMS hospitals that take funding because they feel like their civil rights are being violated, they're being discriminated against, and if they're ultimately terminated, they're going to seek recourse. So what recommendation is the state giving? And then what fiduciary duty do we have to kind of protect these individuals in our state that I feel like, quite frankly, the General Assembly left behind in our recent legislation? Thank you.
Thank you for those questions. And I want to start by saying we're absolutely on the same page. This is a choice, and there are some people who are an absolute no. And it's not hesitancy, and we want to protect that choice, even if it's an absolute no, and even if we disagree with it as public health and medical professionals. That is their right to do that, and we want to protect that. Related to guidance to hospitals, it's not related to, it doesn't pertain to how to coax a few more employees to get vaccinated. It is, how can I help you if you suddenly have 10% of your workforce walk out? It is more of an operational support. It's not, and there's nothing formal. This is these questions that are coming up to say, we're sitting around the table and we're worried about this. For example, one of them asked, are you going to continue to have National Guard if I need those types of questions? Related to your Title VII question, I totally defer to the attorneys on that, but you're exactly right. There will be lots of lawsuits pending.
Representative Ogles, final question, please.
Thank you, Madam Chair. To that statement, I don't know that they're going to walk out. I think they're going to be removed. And if they're removed, or if we intimidate them or force them to walk out, that in itself, I believe, is discrimination, for the record. And I believe they've got recourse. We should not be intimidating employees, forcing them to do something that's so quickly derived. And these are healthcare professionals. This is their livelihood. They work there. They know this better than we do as lay persons, I would say. And yet, if they choose not to partake in something, I think we should honor that. Thank you.
Yes, sir. And your comment reminds me of something that Chairman Todd said, which is when you attach so many monetary strings to it, it essentially becomes, saying it a different way, a hospital or a nursing home can't survive without CMS funding. And so when that is what's on the line here, and they have to choose between sustainability, it puts our hospitals and long-term care facilities in very, very precarious situations.
Representative Lynn.
Thank you very much, Madam Chairman. Commissioner, I just so appreciate my colleagues' statements down here. And there's one other thing that I have been extremely concerned about since this pandemic began, and that is people, when they're diagnosed, especially when they're diagnosed with their doctor, they are not given any sort of at-home self-care protocol in this state. I find it alarming, and I'd like to know, do we have a process to complain about that? Let me give you a couple of examples. All through the pandemic, I heard this from constituents who were diagnosed as positive, but in 1 week, 3 constituents with comorbidities were diagnosed. These are, we're talking heart failure, we're talking heart failure combined with diabetes, obesity, just all of those comorbidities that are extremely dangerous. I asked, what did your doctor tell you to do about this? Go home. They gave me a little oxygen meter, and if my blood oxygen reaches 92, I should go to the hospital. Okay, what else did your doctor tell you to do? What did your doctor give you, provide to you? Nothing. Nothing at all. One woman who was so concerned about herself, she insisted to the doctor, there has to be something. There has to be something I can do. And the doctor said, well, if you want to, you can go to Hendersonville Medical Center and get them monoclonal antibodies. Well, she, very sick, drove herself over to Hendersonville Medical Center. They told her, we only treat 15 people a day with the antibodies, and we've already treated the 15. If you want to, you can come back at 6:30 tomorrow morning, and perhaps you can be one of the 15 tomorrow. So she called me and told me this. So after getting the diagnosis, she called me and told me this. I was alarmed, and she had already called someone else who she knew had COVID. They had actually been together the prior weekend. She feels that she probably got it from that person. And they said, well, we found out that in Trousdale County, they will give you the antibodies anytime you get there, and it doesn't matter what time you get there, just bring your positive COVID test, that's it. And so my friend calls me back and tells me this, and I said, go now, go to Trousdale County. And she said, I don't know where that is. She's kind of new here. And I said, no, I'll drive myself. She was so unbelievably sick. Well, she did get the antibodies, and in a few days, she turned the corner. I did go online, and I found from 2 reputable sources some protocols for at-home care for yourself if you have been diagnosed, and very good common sense things to do. But I'm just alarmed that doctors in Tennessee, because I heard this from several people, we're not routinely giving out a protocol for at-home care, and especially for people who have those comorbidities that are so dangerous. And really, we're just going to drive them to the hospital. Commissioner, what is going on in medical care that this was occurring? Why were people not given better care? And what can the Department of Health do about that? Because this is a major concern, and I'm utterly shocked. And just recently on national news shows, I heard the discussion there too, that doctors were not giving a protocol for at-home care for yourself. All they said was, If your blood oxygen gets to 92, go to the emergency room. Well, your viral load is increasing every single minute. And it is extremely dangerous to have that happen, especially for people with comorbidities. So can
Representative
you
Lynn, if
explain
you
that?
could just.
I just wrapped it up.
Get
Thank
to the
you.
question.
Can
Thank
you
you.
explain that? And what do you think about that? And what can we do about that?
Thank you, Representative. 2 or 3 quick thoughts, and I'll try to be brief, Madam Chair. So the state itself, we don't, no pun intended, we don't prescribe a protocol for medical providers. That is left to the discretion of each individual practitioner. And admittedly, they heretofore have not had a lot of tools in their toolbox. One of the tools that's very, very important and impactful, you've mentioned, is monoclonal antibody. The really good news is we continue to have very ample supply across 220 locations. Just got this week's allocation yesterday, got another 2,300 doses in the state. You shouldn't have any trouble anywhere in the state getting same day or next day. Now, I can't speak to individual facility staffing patterns and when and where they're able to provide that. But as far as the supply, that's not the issue. The other tool that's coming very quickly, probably in the next 2 to 4 weeks, that physicians will have at their disposal is the oral antiviral pill. So essentially the equivalent of Tamiflu for flu. The first one will be Molnupiravir from Merck, and then there'll be another one from Pfizer that probably come out in January. That will become much more of a routine thing. Here's your positive test, here's your prescription. Supply will be a big issue at first, but it's another tool that we're looking forward to.
Thank you, Commissioner. And as I think one thing we've learned through this crisis and this process is that it's definitely evolves on a daily, if not hourly basis, and the rules change because the information that we gather leads us to new conclusions from time to time. So I'm grateful to know that there are, at least on the horizon, other treatments for those who do contract the disease. We thank you again. I think Leader Lambert said it for all of us. We appreciate, we know it's a very difficult job that you have. It's been a difficult position for you and us, frankly, to be in. So thank you for the work that you've done. And again, thank you for being here today. I apologize one more time for making you late and making you tardy for your whatever lunch plans you might have had, probably at your desk. But with that, we will conclude our hearings at this time. I want to thank the members, those of the stalwarts who have remained with us here, for spending your time this way. I hope that we've provided some information that you'll find useful as we come back together in January and begin to look at next year's budget. I wish everybody a happy Thanksgiving, a safe travels home, and see you in January. We stand adjourned.
Thank you, Madam Chair.